I want to welcome you to this forum. It's a bipartisan Senate Task Force on Heroin and Opioid Addiction. You need only to look at the daily newspaper to understand the deep interest in this issue and the real cause for concern. In the State Senate, we are very interested in understanding the full scope of the problem and the full range of ideas to help solve it. Today's forum is one of 13 across New York State and 2 being held in the North Country. There was so much interest. Not only is one being held in Plattsburgh, the one that covers Jefferson, St. Lawrence, and Oswego County is being held today in Watertown. If there's one thing that we know already, the problem has no geographic, regional, or economic boundaries. It's a problem upstate and downstate, urban and rural, affecting children and families. Wealthy, middle class, and poor families are dealing with this right now. Heroin is touching every single corner of our state. We must find solutions that apply equally across the spectrum. Before we hear from experts, which will include a cross-section of law enforcement, treatment, and also from first-hand accounts those whose lives have been affected by this, I want to introduce and thank my fellow panelists, Assemblyman Will Barkley and Assemblyman Ken Blankenbush, for being here today. We are here to facilitate the conversation and to get as much information as we can on how the problem is impacting our families and our communities. We will hear a lot of numbers and statistics today, but for today's discussion, I want you to remember 4. 10, that's the going rate for a single hit of heroin in some of our communities. 23, that's the percentage of first-time users who will become addicted to this drug according to the State Health Department. 87, that's the number of heroin overdoses reported last year to the Poison Control Center in Syracuse, which covers our region. That's nearly 8 times the amount from just 5 years ago. And 414, that's the number of hits that police right here in Watertown seized from one alleged drug dealer earlier this month. And there's one other number that's very important, and that's the number on the Poison Control Center poster up here. That's the number that every household should have next to their telephone. And before we start the program, I want to turn it over to the Assemblymen for their comments. Certainly appreciate them both being here today. Assemblyman Barkley.
Thank you, Senator, and good afternoon, everyone. I want to thank the Senator for holding this hearing and inviting me to attend. I think what Senator Ritchie mentioned about this being kind of cross, whether it's social status, whether it's geographic area, or whatever else, it really is a problem, and we're seeing it in a lot of rural areas, unfortunately. And, you know, it's unfortunate because I think sometimes we think we get some drug problem under control, and another one seems to pop up, whether it's with, you know, back in the 90s or 80s, we had the crack cocaine epidemic. And then we moved into, lately we've had a lot of synthetic drugs, and now certainly this heroin is getting on the radar screen, which is tragic, obviously. So I think this hearing couldn't be any more timely, and I'm thrilled to be here, and I look forward to hearing everybody's testimony.
Thank you.
And again, thank you for showing up, everyone, today, and again, thank you for the Senator for having this hearing here today and inviting me. It's, as the Senator and the Assemblyman have said, this is an important issue, and I'm here today to listen to you, to get as many of your facts and stories that we can get together today. And so instead of me talking any further, I'm going to just toss it to the Senator and we get going so we could hear from you. Thank you.
We'll just start with a few ground rules. We certainly appreciate the speakers who are here today. Could keep your testimony to within 5 minutes. We have a number of speakers who have asked to testify. We also have had numerous calls from people who also wanted to testify. If they want to submit written testimony, or if we have time at the end, we can see if that's a possibility. Sarah Campo will be the timekeeper who will try to keep us on track. We have a limited amount of time from 1 to 3 for the hearing. And with that, we'll get started. Our first speaker is from Jefferson County Public Health and the Watertown City Councilman, Steve Jennings.
Good afternoon, Senator and Assemblyman. Thank you. I want to thank Senator Ritchie and the members of the bipartisan Senate Task Force for working to address heroin and opioid addiction in our state, and for investing the time to hear from your constituents about a plague that is slowly decimating our families and communities. I, of course, have lots of statistics, so get your pen out, Ken. The opioid abuse and overdose epidemic has reached crisis proportions in recent years. A 2012 federal survey on drug use and health reported that the number of people who said they used heroin in the past 12 months rose 79%, from 373,000 people in 2007 to 669,000 people in 2012. The agency also reported that the number of people dependent on heroin rose 106%, from 179,000 people in 2007 to 369,000 people in 2011. It is evident that heroin is highly addictive. The National Institutes of Health estimate that approximately 23% of individuals who use heroin become dependent. The U.S. Centers for Disease Control report that in 2010, opioids, including both prescription painkillers and heroin, were responsible for nearly 20,000 overdose deaths in this country. And while prescription painkillers continue to account for the majority of opioid overdoses, deaths from heroin overdose increased by 45% between 2006 and 2010, fueling concern nationwide that progress in reducing prescription painkiller misuse is being offset by a dramatic rise in heroin use and its attendant social and health consequences, including addiction, hepatitis C, and overdose. Active abuse of prescription opioids and heroin is alive and well in Jefferson County. And as a result, we are clearly seeing increased hepatitis C diagnosis, overdose, and overdose deaths. I want to share with you the impact of what we're experiencing. Hepatitis C. Our cases have significantly risen in Jefferson County since 2001. Hepatitis C is a contagious liver disease that ranges in severity from a mild illness lasting a few weeks to a serious chronic lifelong illness that attacks the liver. Most people contract chronic hepatitis C. Unlike hepatitis A and B, there's no vaccine to prevent hepatitis C. Jefferson has seen its chronic hepatitis C cases jump from 1 in 2001 to 59 in 2007 to 67 in 2013. Jefferson's rise is not out of line with what's occurring statewide and nationally. The increase can be attributed to more testing, which we in public health are pushing, and it's a good thing, but it's also a result of increased high-risk injection drug use, the sharing of needles and other drug paraphernalia, and the resulting blood-borne transmission of virus. Treating and managing individuals with chronic hepatitis C is complex and expensive. Many people currently with hepatitis C choose to forego the care that they need due to lack of access to an infectious disease specialist and the cost for treatment, but this only serves to exacerbate disease and dramatically increase the cost, and right at the point where they face required medical intervention to live. On the overdose front, there's significant activity in our county. Consider the 2-year time period 2011 through 2012. Fire and emergency management calls indicate 698 overdose calls. 301 people visit the Samaritan Medical Center Emergency Department, with 30% of these people presenting with self-inflicted injury related to overdose or suicide attempt, and 25% of these individuals presenting with opioid overdose. There were 199 total inpatient hospital stays at Samaritan due to drug overdoses, with 74% of these individuals admitted with self-inflicted injury related to overdose or suicide attempt, and 38% of these stays specifically due to opioid overdose. Overdose deaths in Jefferson County, particularly those related to opioids, are on the rise. Overdose deaths spiked 80% between 2010 and 2011 and have remained at the highest levels we've ever experienced since. Of the 48 overdose deaths from 2011 to 2013, 79% had a lethal toxicology attributed to opiates. And 50% of these were specifically due to heroin or morphine overdose. Morphine is a breakdown product of heroin. Since 2011, drug overdose has become the leading cause of injury death in Jefferson County. As a city councilman, the drug and heroin use in my city and its impact on neighborhoods, children, and families is alarming and deeply concerning. The Fall Samaritan Emergency Department and inpatient admissions mentioned 48% were residents of the city. Of all the overdose deaths, 44% were residents who lived in the city. So of the total county population of 118,000, only 22% are city residents. These program data compared against population concentrations of city versus rest of county underscore that drug use and all its associated activities and bad outcomes is most prevalent in the city of Watertown. And so a combination of short-term and long-term approaches are needed to combat the drug problem in our communities. And as I alluded to previously, there's great concern that the tightening up of prescription drug ordering and dispensing, which we support, is having the unintended consequence of increasing heroin use and overdose for those opioid addicted. Emerging overdose education and naloxone distribution programs are working, but currently rely on limited funding and loose policy to meet a growing need. Tighter policy and greater availability of targeted funds now through public health and prevention, emergency medical service, addiction treatment and recovery services would hasten the expansion of these programs to meet growing need and demand. Long-term, a legislative commitment to invest and maintain support of opioid overdose fatality prevention efforts within the State Department of Health, county health and mental health departments, and community-based organizations that strengthen the ability to deliver ongoing overdose recognition and intervention training and education, and expand access to rescue medication and other evidence-based strategies are needed to control the current crisis and mitigate it far in the future. To conclude, there's much to be done and no time to lose in the battle against opioid overdose. We need long-range efforts to address the underlying causes and factors which led to this initial rise in prescription opioid misuse and the resultant growth in heroin use, together with immediate action to avert additional deaths and tragedies in the short term. Please feel free to contact me if you need more information, and I thank you for your time and attention.
Before you go, Steve, do you mind taking a couple questions before you go? You mentioned rescue medication, and Narcan has been something that we keep hearing over and over again. Can you give us your opinion on Narcan?
We certainly are supportive of expanding its access and availability in the community. We worked most previously on getting it on our basic levels, basic life support squad levels. The advanced life support squads could carry and administer it at the basics. And so that policy was enacted recently. There's a great push to have law enforcement carry it. And I think the Attorney General recently sponsored something in that regard. I think the policy's loose, and I think we need something tighter and broader statewide on naloxone. And there's great controversy with law enforcement on whether they should administer it or not. Some agencies are very much for it, others are not. So working on that front, I think, would be a benefit.
You gave a lot of statistics. I'm sorry I missed it. I think I heard that all the overdoses you have, 25% are related to opioids, or I guess in heroin. And what does that equal in the numbers?
In the numbers?
Yeah.
So between 2011 and 2013, so we had a total of 48 overdose deaths. 38 had a lethal toxicology attributed to opiates, and 50% were specific to heroin and morphine. Of that 50%, 6 were heroin, 13 were morphine.
And then I'm sorry, Steve, I should know what you do, but I know you're on the city council, but are you also involved in that hospital, or?
I'm a public health planner
Oh,
with
you-
County Health.
oh, I apologize. I should know that, I'm sorry. So, I mean, the general addiction of these things is because people were on prescription drugs and then moving off of prescription drugs because they can no longer get them, presumably. Is that the case? So they're looking for an alternative?
Or it's a combination.
Or a
Many
combination.
people have, we call it on board, they have many drugs in their systems when they expire.
Right.
It's often a combination.
And what's responsible for the cheaper price for heroin now? Do you know?
I don't know.
We usually think a lot of demand out there would
There's huge
cause the price
demand.
go up. I
And
mean,
you can, I'm sure law enforcement will talk about the
Yeah.
bus we've been seeing recently.
right.
These people are selling huge quantities of it. I'm glad we're catching them.
Yeah.
We're probably not catching all of them, obviously.
Thanks.
Steve, is there an age bracket that is more, is it a middle?
Tends to be more middle. People have a perception that it's young people, really young people, but it tends to be high 20s through young 50s, I would say. That's predominantly. You're asking about deaths. That's for the
What?
decision deaths. I think addiction is probably all of them.
Thank you, Steve.
Thank you, Senator.
Next, we'll have Nicole Smith from Jefferson County.
Hi, good afternoon. My name is Nicole. I'm very glad to be here. A little nervous. I came just to share a little bit. I've been in recovery since March 4th of 2012. Since that time, I'm now enrolled in the Economic Dependency Program at GCC. I'm working. I'm a single mom. I have been able to restore relationships with family. I practice yoga. I have a sponsor. And there's just so many things great about recovery that I wish more people could experience. I would like to share everything that I have experienced with others to try to help them, and just be someone on the same level and understanding. I did have about 10 years where I was addicted to cocaine and prescription drugs. My son lost his father at 31 years old due to the disease of addiction. I've lost several friends as well. I lost my son for approximately a year. I have full custody back, raising him on my own. As I said, going to school, working, and just enjoying life positively in recovery. And I'm very grateful. My faith has been a big part of it as well. Everything's different for everybody, but that's been huge for me. So, as I said, I'm just very grateful to be here. So thank you very much.
I want to say how much we appreciate you coming here and sharing that with us. And if you're comfortable answering a couple questions.
Sure, that's fine.
Can you tell me how you first got, I guess, the opportunity, or what made you the first time try whatever you started with? Well, just so other people can kind of know what happens that I
As
think
far
pushes
as-
somebody the very first time to try it.
I think a lot of it was due to peer pressure. I mean, that's always a big issue. I had unresolved issues dating back to childhood that, I never handled properly. Addiction is to mask, drug use and addiction is to mask unresolved issues, feelings, things that just never were addressed properly. I have been in counseling, things like that. I was on antidepressants for years upon years. I no longer need to take them today. So that's something that, says a lot about where I'm at in life and how positively things are going. So.
And what was the turning point to get you to the point that you were seeking help?
Well, it took me a few times. Most people it does. Doesn't usually happen the first time, unfortunately. I would say that the major turning point was CPS becoming involved with my son. And, you know, saying, you can't see your son anymore. That was my bottom. Everybody's is different. Sometimes that's not even enough for certain people, you know. But that was for me, that was it.
And was it easy for you to find services when you got to that point?
Yes, I think so. I mean, if you look, it's there. You know, if you really want it, that's what it boils down to. It's there, it's available.
Thank you.
Yes.
Thanks for testifying. It's actually
You're welcome.
going to be very helpful for us. But, and just to follow a little bit up on Senator Ritchie's comments about, yeah, I guess we're trying to hear testimony what we can do in state government to help people like you and others that have been addicted. And maybe you don't know, but can you explain what kind of roadblocks you might have had that we could change or take out that would make recovery easier for people? Obviously, funding is always a big issue, but...
That's what I was going to say. That's insurance issues are, you know, I know that financially, I've heard people say, well, they can't afford, you know, to get the help that they need.
Yeah.
I think maybe any kind of way to put out there, you know, that there is help, any kind of, just so it's more available for people to see, I think, you know.
Do you think, I'm sorry to interrupt you, do you think education would have been beneficial to you, like at an earlier age, or, I mean, did you feel like that? I know these are hard questions, and maybe it would, maybe it wouldn't, it's hard to say, but would you think that's...
A little bit, maybe, yeah, a little bit more in the school system, a little bit more education, because really people don't understand what it is to be addicted. They don't, there's a lot of discrimination against addicts.
Yeah.
People have the facade that they don't change. It's not true. You know, it just, I think a little bit more education.
Thank you.
Nicole, just one.
Sure.
You said you were addicted to cocaine for 10 years. Was that was that your drug of choice at first? And was that because of the cost of it, or the availability of it, or why one day did you say?
It kind of just started out as experimenting, which normally is the way it goes. I think it's availability.
I certainly appreciate you coming here today, because your testimony, along with some of the other testimony that we're going to hear from people whose lives have been affected, I think is really what's going to help us find ways to help. And I know when I initially saw the statistics, the one that really jumped out at me is that almost a quarter of the people who try heroin are addicted from that point. And if you're a young kid and you're out with your friends and you try it once, that could affect your life, you know, forever. And that truly was really alarming. So we appreciate you coming and sharing your story. Thank you.
You're very welcome. Thank you.
Thank you. Next, we have Jefferson County District Attorney Cindy Enchert.
Good afternoon. First, I'd like to express my appreciation to you, Senator Ritchie, also to you, Assemblyman Blankenbush, to you, Assemblyman Barkley, and the members of the Joint Task Force for recognizing and addressing the havoc that is absolutely being wreaked in our communities by the onslaught of heroin, prescription drugs, and other opioids that are flooding our streets. Based on the cross-section of representation that's here today, it's clear that this is a community-wide problem that affects the health and safety of our citizens in a myriad of ways. And as this is not a singular problem, there's no single answer. Again, thank you for seeking out our perspectives on this issue. Let me briefly share with you some of my observations as a prosecutor with the Jefferson County District Attorney's Office for more than 28 years. Although I don't have any statistics in this regard, I have to tell you that I don't recall hearing about heroin cases in my early days as a prosecutor. Those that existed, if any, were definitely the exception and not the rule. This general trend continued until just a few years ago. In 2007, 3% of the drugs seized by the Metro Jeff Narcotics Task Force by searches or by undercover buy involved heroin. In 2009, that percentage rose to 10%. In 2012, 27%. In 2013, 38%. And to date, in 2014, approximately 40% of the drug arrests by the task force involve heroin. Particularly noteworthy is the fact that the cost of a bag of heroin, as you've already mentioned, Senator, is less than half of what it was just 1 year ago. And if that's not an indicator of supply and demand, I don't know what is. Arrests involving prescription drugs, while nowhere near as prevalent, have also seen higher percentage numbers in recent years. The growing prevalence of heroin addiction in Jefferson County is reflected in the defendants who've been referred to Jefferson County's drug court since we began operating in 2002. Drug court is designed to target and to assist those nonviolent felony defendants who offend primarily due to drug and/or alcohol misuse and addiction, and for whom standard rehabilitation programs, quite frankly, haven't worked. It's hoped that through intensive drug treatment, mental health treatment, and through regular and consistent court contact, these defendants can recover from their addictions, lead drug and alcohol-free lives, and become law-abiding, contributing members of our society. The number of defendants who have participated in drug court over the last 6 years, for whom heroin is their drug of choice, has on average been double the number of heroin defendants that we saw in our early years of operation. You've heard some, you'll hear more today, but the effects that we see from heroin and opiate addiction are absolutely devastating. The intelligence gathered by law enforcement indicates that many addicted defendants are telling us that some of them will do anything for that next fix. They'll steal from their parents, their grandparents, their loved ones, their friends, to get the money for that next high. They shoplift, forge credit card receipts, and burglarize to obtain goods to sell. Young women are prostituting themselves for the drug or for the money to buy it, and they leave their children unattended while they focus on that very next high. Heroin waste, including used needles on the streets and in our recreation areas, is yet another public safety concern. As you know in our hearing here today, this is a multifaceted problem without a single answer. The focus on attempting to control the illegal sale of prescription drugs needs to continue. We know that many turn from pharmaceuticals to heroin because heroin is half the cost on the street and often provides a quicker, more intense high. From the criminal justice side, we're attempting to reduce both the supply and the demand of heroin, opiates, and all other illegal drugs. I don't believe that there's a single elected district attorney who believes that the appropriate answer is to simply lock up everyone who's offended because of a drug problem. Each case needs to be reviewed individually. And while I can't speak for my colleagues, I believe that each of us looks to rehabilitate through the criminal justice system where appropriate, while still holding people accountable for their criminal actions. That rehabilitation can take different forms and require many different resources, including substance abuse service providers, mental health counseling, and when necessary and appropriate, incarceration. Those efforts target the demand for drugs. Excuse me. Our law enforcement and prosecution community, including the Drug Task Force, also works to reduce the drug supply. There's been a significant relaxation of our drug laws in the last decade, and we continue to work within that framework to take drugs and dealers off the streets. I believe, personally, however, that the available programming for repeat drug dealers, we used to call them pushers, could be tightened up. Perhaps more resources could be devoted to screening out those dealers who, after conviction, work the system by claiming a non-existent drug problem, and in so doing, tie up the rehabilitation beds, the substance abuse counselors, and the mental health workers that are needed by the true acts. Again, I thank you for your interest in addressing the issues today, and I appreciate the invitation and opportunity.
Thank you. Just a couple questions. Cindy, can you tell us where the local heroin seems to be coming from? Do you know?
I prefer not to get too specific, but I would say south of here, from some of the larger cities coming up north.
I know you mentioned earlier how heroin didn't seem to be a problem up until just recently, and I know until people started calling the office and asking for some help, whether it be law enforcement or either someone looking for services. In the past, when I heard of heroin use, I would immediately think it wasn't in the area, and it was something that was coming from New York City. So it is really hard to believe that this problem is so prevalent in the 3 counties that I represent, and appreciate all that you are always doing to stay on top of everything. And just one more question, just for my own personal knowledge. Can you just tell me what happens if you suspect someone is using heroin? Just kind of walk me through what happens if if an officer pulls over someone, how it ends up on your desk. Is everyone pulled over, is case referred immediately to the DA's office, or?
If someone is pulled over and the officers have probable cause to search the car and they make an arrest,
Mhm.
that case is referred to the
That case is
district
automatically
attorney's
referred.
office. Yes.
Okay, great.
Thanks for your testimony. Just 2, I guess, relatively short questions. How is heroin usually ingested? Is it needles mostly, or is it, I mean, you can smoke it too, right? Or do you know?
It can be smoked. It's also an injectable drug. I think the general intelligence is that that it's injected, but it's also being made available in pill form,
Right.
capsule form. Excuse me.
Yeah, interesting. And then how, you mentioned maybe stronger laws for those who deal in this drug. Are heroin dealers unique opposed to other type of drug dealers? Or is there a drug dealer that sells whatever you need, or what's your experience with that? And then, I guess, specifically, any idea of what kind of laws to strengthen that you're looking for against heroin dealers?
Again, I was referencing those cases where individuals have been convicted and they're headed to prison.
Right.
And when they have an addiction problem and there are programs available in prison, that's rehabilitation. But those individuals that are playing the system and
Quite frankly, consider the cost of doing business.
Right.
Indicate, well, I haven't used up my shop yet. I haven't used up my KSAT eligibility. I haven't been a Willard yet.
Right.
That's a concern. That's a concern for those individuals that can truly benefit from those
Now, do you think that's
programs.
local, or do you think those people are, I mean, so what I'm saying, is there a big drug dealer somewhere along that's pushing us off to maybe smaller dealers, and then how it gets up to our area is mostly abusers that also tend to be drug dealers too? Is that?
I'm sorry, with regard to the playing the system?
Well, yeah, so, I mean, I would see the ones that are playing the system are either mid-level or high-level dealers. I assume there's, again, I'm probably saying more than I know, I assume there's dealers out there who are also addicts, and they just happen to be dealing because they are addicts and they're trying to
Correct.
pay for their own
Yes.
habit, I
Yes.
suppose. I mean, is that, I would also guess, and I don't know this, I guess I'm looking for confirmation, that's primarily the type of dealer you have probably in our areas, or no, maybe not, or you don't know?
I think we see both.
Okay,
I think we see both.
Okay.
Thank you.
thanks.
Yes, Cindy, in the news nationwide now, you're hearing in the news where there are going to be some releases from prisons because of judges having mandatory sentencing on on addicts that have been put in prison, and that there are going to be some leniency. And in New York, is there mandatory sentences if you're convicted of certain drug-related crimes in the state of New York? Or does the judge have the availability to look more at, instead of jail, putting them someplace to get help?
There's considerable more discretion by the judges, and quite frankly, those of us in the system who are trying to craft, the appropriate disposition. There is some mandatory sentencing. Much of that was taken away in what we refer to as the Rockefeller revisions.
Again, I think it's we've spoken of those individuals who deal, who prey on others, those individuals who are dealing in small amounts, which in turn preys on others, but it's also done to feed an addiction. So you've got the businessman, if you will, or businesswoman, versus he or she that may be motivated by their drug problem. And I think that there may, again, it's a matter of resources in order to, to be able to ferret out who's playing the system. It takes time, it takes trained individuals. And I don't know if that's somewhere that the state would like to expend resources or not.
Cindy, I just have one last question to follow up. If there was one thing that the legislature could do, in your views, to help the situation, what would it be?
One thing?
Well, if you have more than one thing, that's okay too. So.
Oh, boy. I think, again, I think laws that permit us to target the actual dealers and to see that they're not headed toward some of the programs that others can benefit from and be rehabilitated and come back out and be contributing members of society is great. But in order to have those programs work, whether it's with an individual who is on probation, who has voluntarily said, I have a problem and I need help, our service providers need money and need people.
Thank you.
Thank you.
Next will be Mark Koser from Madison County.
Senator, good to see you again. Assemblyman, we met a month ago, maybe two, and we chatted briefly about this. So I have the honor of thus far spending about $400,000 in 5 rehabs for one of my sons. It's been an 8-year process. It's pretty devastating to the family. What happens is, in the beginning, you send your son off to rehab with the hope that they're going to get fixed. That typically doesn't happen the first time around. But they do get sober, they come home, and you have all the hope in the world, and then some short period of time later, back they go. And now, you still have that same hope. It's your child. And the worst thing for a parent is to lose a child. So you dig into your pockets, you come together as a family, and you send them back off. Well, for me, that happened 4 times. On the 4th time, what I was told by all the counselors is that you cannot do it again. If your child is going to die, they're going to die. So if they know that you will help them, they will continue doing what they're doing. So I wasn't going to help him, and about 90 days ago, he overdosed, or should I say died, 4 days in a row in an apartment in Utica, at which time the counselor said, I think he's ready. So I did it again. He's now in Florida. He is 90 days sober, which is great news. He is finding it hard right now to get back into society, because for 10 years or 8 years he's been out of society. So he also knows that he is $150 away from death. All addicts know that. If he decides one time to do anything, he'll be dead in a week. It's that devastating. So one of the questions is, how did he get started? I suspect that'll be a question. So 8 years ago, my wife of 30 years had a brain aneurysm and dropped dead in front of me, which was pretty devastating. We didn't have any warning. I didn't, and neither did my kids. And we live in a small town, and at that time, doctors were prescribing painkillers almost like candy. Seriously. My son had a bad back, and this is definitely cleaned up, but in the receiving line at the funeral, the doctors in my town told me and all of my children, whatever we wanted to help us deal with the grief, they would help us with. And within 2 months, from my 12-and-a-half-year-old daughter, who was taking Ambien, to my 16-year-old son, who was taking Xanax, to my next son, who generally stayed out of it, to my oldest son, who had a bad back and was taking painkillers. I stopped all that. I thought I did. But at that time, he could get the painkillers easily. He would get 2 vials a month of 180, sell with the 180 for $5 a piece. That's how he made his living, and then do the other. He would take the other. So from that time, you progress to more and more painkillers, and then you realize that heroin is way cheaper, way easier to get, and feels a whole lot better. And that's the problem we have now. In my little town, just last week, 7 teenagers were arrested for heroin. I'll say less than a month prior to that, 3 men in their late 20s were arrested for heroin. So I know this, that if I was going to invest in a sure thing, I would invest in a chain of rehabs. I'm not trying to be funny, but it's very, very serious as I see it. And so for me, I believe that we need to look at the laws. If a drug dealer deals heroin, how many people is he going to kill? I mean, this is death. Does it go to manslaughter? I don't know, but it literally, you are dealing something like guns that will kill. There's no ifs, ands, or buts about it. And my son, like I say, was dead more than 4 times. So how do you change the laws? I don't know. But I remember a friend of mine went to China, and if you got caught shoplifting, they would cut your arm off. So guess what? There wasn't a lot of shoplifting in China, in my opinion. So I don't know what needs to be done law-wise. I do know that we were lucky enough to be able to send my son to good rehabilitation centers. But it was also $400,000. Most people are not going to be able to do that. So government subsidized rehabilitation centers, I think, are, I don't even know, we didn't really look into any. I don't know what that situation is. I got to think our jails are going to be filling up quick if they're not already full, because it is an epidemic. So that's my story, and I'm glad to be able to speak about it. And right now, my son is 90 days sober, so we're on the path. Thank you.
Well, first, I want to say thank you for testifying. I know it must have been difficult considering what you've gone through. I'm glad to hear that your son is 90 days on his way to a productive life. I know that you mentioned that it's difficult for him now. Is that because after someone has been for 10 years kind of out of the ability of getting a job or going to college, is that why it's difficult for him to get back into day-to-day activities? Or
I think it's probably similar to getting out of jail. And you get out of jail and all of a sudden you're in a whole different environment. So for 10 years you've been lying, or 7 years, or 8 years you've been lying, cheating, stealing, There was a lot of times he would just go to the stores, shoplift for enough to go to the pawn shop and get enough for that night. The next day was the same, day in, day out. And he had a wife and 3 children. So, yes, sorry, I just felt some emotion. I actually lost my train of thought.
So now that he is in a much better place, what can be done for someone like your son who has gotten over this huge hurdle to help them continue on this path? What does there need to be more services in place to help those that are recovering find jobs that are something that would help them remain clean? Is there
The outpatient aftercare is as critical or more critical than getting them sober. You can take an addict, put him into detox, and get him sober in a couple of weeks. In a month, 2 months, he's a different person. It's the afterwards that is critical, which is where he's at right now. I could get a call tomorrow that he's gone. So we are paying for aftercare, which is counseling 3 times a week and meetings every day.
Just one last question, because it's been 4 times that he had gone through that previously. Is there something in particular that would trigger him to start over, or I'm just trying to figure out what the best plan of action is, if there's a need for certain services in the community, if what makes this time so much different from your son, because he was at the very end and that's why he's in this place this time? What can we do to help people get to this point before they get to the very end and have to go through what he did?
That is a great question, and the answer is you can't do anything. Once they are hooked, until they get to a bottom, as we discussed, and everybody's bottom is different. His bottom was death. So the key is education in the schools, and to do our best to prevent people starting on it. And I would say that that's a start for sure. I really believe that laws for dealers should be hugely tightened. I think we need to look at it differently. They're not drug dealers, they're murderers.
Yeah. Thanks for testifying. Your testimony is very powerful. I guess the question I had, and I think you hit it on a little bit with Patty's question, but so he was in rehab 4 times. Did he go to the same treatment center all 4 times?
The 5 rehabs, the last 2 have been the same. No, back up. The last 2 have been in the same location, 2 different rehabs, but several hundred yards apart.
Is there any kind of, I know you said outpatient treatment is more important than the actual treatment, but was there any difference between the treatment centers that you think was more effective than when he went back, obviously, so it couldn't have been all that effective?
The treatment centers that he was in initially were very strict. Ties to dinner, no smoking. He's very intelligent and actually brilliant, and he loves to break the rules. So the treatment centers that worked were the treatment centers that said, we will help you if you want to be helped. There were no fences and no particular rules. So they gave you enough rope to either kill yourself or succeed.
And so after he had those 4 episodes where he overdosed, that's what, as you said, was his bottom, and that's what got him into the...
That was it.
And were these all in-state treatment centers or all over the place, or where were they?
There was 1 in-state, 4 out-of-state.
Yeah. Okay, thank you.
Thank you very much.
Thank you.
Next, we'll hear from the Oswego County Sheriff, Rule Todd.
Again, I want to thank Patty, or Senator Ritchie, for putting this together, and our assembly people for being here. We have, without even saying it, a huge problem. Heroin is extremely addicting, as everybody knows. Its use in the past 2 years has more than doubled. And in 2002, there are about 166,000 people, according to the NIJ, addicted. By 2012, it was 335,000, and they say it has more than doubled and maybe tripled in the last 2 years. And I've already been asked by a couple of people what I think, and I believe the retraction of the Rockefeller drug laws, which reduced the penalties for the possession and especially the sale of heroin, has greatly enhanced the penalties, or the ratio of probability of the crime to the punishment. There is no punishment. If someone comes in now and says, well, I'm not just a seller, I'm a user, we send them off to a drug clinic where they pick up more clients. Lack of jobs and lack of punishment all combine to make this a huge problem. A few years ago, we had a problem, a really huge problem with bath salts. Nobody paid a lot of attention at first. It wasn't affected by law. It was legalized marijuana. Then young people were getting killed, same as they are now with heroin. They were doing crazy things, walking in front of cars, trains, jumping from buildings. There isn't any day just about you go by and look at the, read the New York Post that there isn't somebody that's jumped in front of a subway car down there. It's continued to get worse. More kids have died. We need to do something. We investigated on the bath salts. We changed the laws and we started locking people up. The guy that was importing it from China got, what, 16 years down in Utica. 16 years. It's not enough, but it was something. I mean, if he got 16 years for every death, for every child that died, I would say it might have been good, because you're right, these drug dealers are murderers. One of the most viral YouTubes, the video, come out here in Watertown, where a child brought some of this legal marijuana or bath salts. The parent took the law into his own hands, which I don't condone, but it's hard for me to disagree. Went in with a baseball bat, destroyed the shot. That's when everything went viral and it started to draw a lot of attention. The guy gets arrested for losing his child. Another family from our county, whose son drowned after he used bath salts, went public demanding legislation, and I know most of you people supported that legislation. What do you hear about bath salts now? Very, very little. Because the law was strengthened, we punished the people, we made it not profitable. As long as it's profitable, they will continue. Every day, according to the NIJ, there are 105 people that die from overdoses in this country, 105. But we take the laws and we strengthen things and take away guns from legal people, but we're not doing anything, really. We're closing prisons. We weaken the law, the Rockefeller drug laws. When you look at what has transpired, the last 5 years, when they took away the Rockefeller, decreased them, the Rockefeller drug laws and the penalties and everything else, what has happened with the drug trade? It has increased dramatically. Look at what we're doing. With all the tax money that I see wasted, it doesn't make sense to me to be weakening the laws and closing prisons. If we have this much drugs, we should have a lot more prisoners. That's all I can tell you. And we save the money, tax money, we supposedly don't take from the people, and we give it back to the people to spend on the funerals of their children. I think it's time that we all got viral again and started saving the lives of our loved ones. My views.
Thank you, Sheriff. What ages do you, have you been seeing in Oswego County that have been affected? Is it across the board?
It's pretty much across the board. And again, these two people, this gentleman over here and this young lady that talked, I'm so proud of them because I had a very close relative, a brother that was addicted, and I went through the rehab thing. You have to have a sponsor, and I did it with him, and it's amazing. But I can tell you, neither one of those kids, the first drug they took was heroin or cocaine. Am I right? Alcohol, weed, right on up the line. That's where it starts. It starts alcohol at a young age. Because alcohol, well, it's better than cocaine, right? It's better for him. We see it in every, we had a Narcan saved a 17-year-old in our county the other day. But I had a 48-year-old neighbor 2 months ago that died from a heroin overdose. And the thing about it is, what you're putting in your body, you don't know. Because when these, if you get a hot load, which is anything more than 7%, at least that's what it was when I worked undercover in 78 and 79, your average dosage of heroin is about 4%. Everything else in there is just cut right down. Whether it's Drano, you know, same stuff for bath salts, battery, all this stuff. They mix in there. Rat poisoning, they don't care what they put in there, but they make more money. But if you get a hot load from somebody that maybe hasn't cut it again, and it goes up, if you go from 4 to 7% heroin, your heart explodes. It just plain blows apart. The valves and the vessels and everything in there just blow apart. So I'm telling you, right from the 16-year-old up to the 48-year-old, we're seeing it.
I know Assemblyman Barkley touched on this earlier, and I've heard from a number of law enforcement individuals who believes the I-STOP program has been so successful that it is forcing more people to use heroin. Do you think that's true?
I believe it is, and again, that's, again, the I-STOP program is a great, any program that helps anybody. You know, my brother, who again went through this, and never give up hope, because I honestly didn't think then that he would make it through the program. Don't ever give up hope, because you never know. When they finally hit rock bottom and they realize it, they're either going to die sometimes, and sometimes they do, I'll be honest with you. But never give up hope. It helps, but again, when you can go to mental health facilities, like he was saying, get a prescription of 180 pills of quasi-drug, of a drug that is, they give you to help you get through the effects that when you don't have that, and they take it out and sell it for $5 or $10, take the money and buy cocaine or heroin, and heroin is so cheap now compared to what it was when I worked undercover, and we saw very little. In 78 and 79, we saw very little heroin. It was all weed back then, and they're important into so much. If you got a package of heroin that's that big, you're talking thousands and thousands of dollars. You take the cost of weed is up compared to what, it's kind of reversed itself. A bag of weed is worth, that's about $40 now, and that's what heroin was, and a little pill like that now is $5. So.
Well, 78, 79 was a long, long time ago.
Well, I don't want to date myself, but yes. I've been in here a long time.
Just a quick question. Well, I don't know if you can answer, Sheriff, excuse me, I don't know if you can answer. It's not the DA mentioned that 40% of the drug task force, I don't know if they're arrest or whatever, covered heroin. Do you have any idea where heroin stands in Oswego County compared to meth or synthetics or any other drug?
Heroin is picking up very fast in our county. Meth, we've concentrated so much on so many of these meth labs. When all of a sudden the price of heroin has dropped so much, people were turning in their neighbors and stuff for making this. We aren't seeing as much meth now as we are heroin, because it's there, you can get it.
Thanks.
Thank you, Sheriff.
And again, don't give up.
Next, we'll have Adam Bullock, RN and Director of Behavioral Health Services at Canton Potsdam Hospital.
I want to thank Senator Ritchie for having me here, and thank you to the Assemblyman as well, and for listening to us today about what's going on with heroin. I'm the treatment side of things. Canton Potsdam Hospital, we have an outpatient clinic for chemical dependency. We have an inpatient detox program. We have an inpatient rehab and also a behavioral health clinic, psychiatric clinic. So I see folks on all spectrums of the problem, let's say it that way. And what I've given you is kind of showing some of the increase that we're seeing on the treatment side. The blue, and what you'll see first is 2011. You'll see a doubling from 2011 to 2012, and then again it doubled from 2012 to 2013 across all of our service lines. That's with the heroin use. The next sheet is your opiate percentages. You would think, and with iStop and with the increase in heroin, you would see a decrease with the synthetic opioids. However, you're not. You'll see that in that second page, opiate use percentages. Not until 2013 are you seeing some of a decline in that. Some of it's iStop, some of it's the increase of the availability and the cheapness of heroin. In your last page, you will see is comparing the quarters, 2014, to give you a snapshot of what's currently going on, to the last 2 years. You see detox from 12 to 14, increasing from 16 to 45% of the folks we're seeing. Rehab has gone from 18% to 53%. And outpatient continues to rise as well. But there's a drastic jump on that last page, kind of showing the fourth quarter. I am open to questions. I just wanted to give you a little bit of what we're seeing.
Can you tell me if you believe there's enough facilities or treatment centers here as far as the increase in the number of heroin users?
It's an interesting question. There's plenty of beds. Canton Potsdam Hospital, our rehab, where you would think, and that's kind of what you're talking about, is that inpatient rehab or outpatient. Our occupancy rate's around 87% in our rehab. The reason that you see an epidemic and you don't see patients in the beds doesn't make sense, does it? Through this increase, we've also seen the decrease in payers. We've seen the inability to get patients into treatment facilities. They continue to raise the standard. An individual hasn't failed at outpatient. They haven't failed enough at outpatient. It doesn't matter what the data is. I have a young woman in treatment right now who is a registered professional nurse, using at work, showed up at had some other issues, child protection involved. Insurer allowed us to have her in treatment for 12 days. We tried to re-review that this morning. The insurance company denied us and said, the doctor from the insurance company said, had you called me previously, I wouldn't have given her any days. This is a woman that also has failed at outpatient therapy. This is nonstop. It's every day. It's a battle that we fight.
Can you elaborate on the process of how if someone is trying to get help and seeks out your services, what the insurance company can or cannot do?
They can deny access to treatment.
And is there any appeal on that? If
No.
somebody comes in, is looking to turn their life around and to get into, to have some rehab services, you're telling me that the insurance company can just come back and deny them
Absolutely.
payment?
Absolutely. Amen?
So
It's the biggest problem you have. The insurance company issue is bigger than the heroin problem because you can't get anyone any help. Emergency room. I fought with an insurance company the other day and I said, you're shooting your own self in the foot. Instead of getting their subscribers the help that they need, they'll continue to pay for emergency room visits, they'll continue to pay for detoxes, they'll continue to pay on these other, and they don't even look at the data. I said, look at the evidence, but they continue to deny.
What do they tell you, what the reasons why the denial, just that it's not covered?
Sometimes there's a coverage, but they're not qualified.
I don't get that. Can you explain it?
Say you call us and you're looking for, say you're looking for a rehab bed. Sometimes I can't get you in at all. You don't have a benefit, it's some of it, but you do have a benefit, but you don't qualify because you haven't tried outpatient. You've only failed once at outpatient. You should try to go to an intensive outpatient before you can come to rehab. So, they raise the gradient. It does not matter what's going on in your personal life. Then we'll say, okay, after you fight with them for an hour, they'll say, okay, you can come in. We'll give you 3 days. The counselor doesn't even have time to write a treatment plan in 3 days, and we have to call the insurance company. We're not even to the bottom of it yet. They'll give us 4 more days. What do you do in 4 more days? You try to collect more data, you try to work. The patient doesn't even have his bags unpacked because they know that they're going to have to leave. They'll turn around and they'll ask them to leave. I have a pregnant individual have to leave us after 7 days.
What's the normal amount of days that is needed for somebody to recover in rehab?
I'm not able to answer that question. Ideally, you would want at least a 28-day stay in the rehab.
Okay.
It depends on the individual circumstance, socioeconomic status.
Well, I understand there's a variable, but
Yeah,
when you're
it's
talking
difficult.
3 days, 4 days, and maybe 7 days, that's a far cry from 28 days. So in the end, they're actually wasting their own money because they're not giving you enough money to even accomplish anything.
Exactly, and they don't
So-
get that, and that's the argument we continue to use. But you don't see them buying the logic. 14 days is your typical now. The biggest issue that we've seen is when we've started seeing a lot of the managed Medicaid products. There were some individuals that were able to get help. Managed Medicaid stepped in, the VHO stepped in. That was one of the worst things that had hit us, was every patient who had had the VHO, the Behavioral Health Organization, and we had to call in all that information, we would spend hours. And we continue to spend hours on those individuals now. I see our friends from Samaritan shaking their heads also. Hours of time. Now I'm supposed to be have my hands tied trying to help somebody, and I'm spending all my time on the telephone fighting with the insurance company. And I can't even be in with their prescriber. It's not mine. This isn't a person that I'm paying for that stay. That's what's happened with the BHOs. It's gotten worse and worse. The fight has gotten harder and harder. The length of time that it takes for the insurance company has gotten longer and more difficult.
We didn't get dime one out of 5 rehab from the
It's
insurance
insane.
company. I wasn't gonna fight with them. It's done.
That's right, they
So
won't
it
pay
sounds
for
to me
it.
like you have $400,000, you could get rehab.
I got a friend that had to refinance his house. His son's in rehab right now. He'll be in there for 3 days, come home and go right back into it, I'm pretty sure, because that's just enough time to dry him out.
Well, there's very few parents who would have those kind of resources, and we certainly commend you for staying the course with your son. But what does that mean for, the majority of families who don't have those kind of resources? What happens to their family members?
Yeah.
They come in and they stay for 3 days and they send them home, and then what, they end up at the emergency room?
Yes.
And what happens at the emergency room? They're signed up for outpatient services?
Nothing.
Nothing? They just get them through that small crisis and then they're sent back?
Yeah.
to the
We also,
situation?
at Potsdam, we have a detox unit. We have 7 beds on the detox unit. There's 54 people waiting for beds with opiate issues for those 7 beds. While they're waiting, what do? The withdrawal symptoms of opiate dependence and opioid withdrawal, they have nausea, they have vomiting, there's anger, there's chilling, there's sweats, they can't eat, they're curled up in a ball, waiting for a bed. They show up at an emergency room. No one's going to give them the opiate to take them out of withdrawal. No one wants to give them a benzo, a Valium, or something to keep them at ease. Generally, they'll give them a little bit of clonidine, maybe a couple Valium, and they send them back home. It's exactly what happens until they finally detox on their own at home. I frequently hear, I detoxed at home, I'm ready to come in. Because one of the questions we ask in a rehab or when we do evaluations on the outpatient side, are you going to detox? When is your last use?
So is that what you're referring to that they haven't gone through that process first before they're allowed to go to Canton Potsdam for a rehab to an actual facility?
Yeah, if you want to come into rehab, or the facility, we want to make sure that you're able to engage and you're not going to go into withdrawal. If we put you in a rehab facility, we want to detox you before you come. So they'll just spend a couple of days there. It's a 5-day methadone taper. Or if it's alcohol withdrawal, which is life-threatening, has to be treated before you can engage in treatment.
And this is my last question, I
Well,
promise.
kind of veered
And can you tell me, for those that detox and then they don't actually get to go into like a rehab program, what's the statistics on their success rate after?
I don't have statistics, nor does anybody. Success rate, people are lost to contact, people are dying, people are moving on, going to other treatment facilities. There's no data on that. We'll be continuing to see. You will see also at percentages on readmission rates that we had. For the 3 years I gave you representation, 623 admissions to our detox, 45% of them were readmissions. So about half of the people came back in that were able to. With rehab over those 3 years for 296 admissions, 28% were readmitted, 83 in outpatient, 64% are coming back into the cycle.
I guess I'm going to have to ask you one more question after that. Those that aren't coming back are those that aren't coming back in for rehab the second time, are you assuming that they're able to hold a productive life and not use the drug again, or are they just not coming back because they've given up hope?
My mindset is that one, they're incarcerated, two, they're in another treatment facility, a small percentage are healthy, and the rest of them are no longer with us.
That's pretty scary.
It's the truth.
Thank you.
Just two questions. I want to follow up. For detox on heroin, you use, what's it called, methadone?
Use methadone.
And I know with alcohol detox, it is very dangerous during that time. People, is it the same? Because with some drugs, there's not a problem with, as far as life-threatening detox. Where does heroin fall in that? Is that more like alcohol?
Alcohol withdrawal is life-threatening because of cardiac instability, seizures that happen. Heroin generally is not life-threatening. The individual feels like they're going to die.
Right.
Generally does not.
Right. And the information you gave us, you have percentages here. I assume that's percentages of all drug use. Is that what 100% is? And then the
100% would be all patients.
admitted patients for drug use.
Yeah.
And then is this on the last page? You
No,
have
that's drugs and alcohol. Of all our admissions, that's percentage that were heroin.
Okay. Drugs and alcohol. And then is this the number in the last page? You have first quarter heroin use percentages, and then you have 60 on the left-hand side. Is that the number of admitted all for drug and alcohol in the first quarter?
Yeah, we just use 60 as our gauge because we've gone over the 50. So 50, if you look at the second one, rehab, the green was 53. 53% of our current patients in the last 3 months in rehab were there for heroin.
That's a
This was
percentage,
primary or
okay,
secondary
that makes
diagnosis.
sense. Then, so what are we talking, I guess what I'm ultimately trying to get at, what are we talking about actual numbers here versus percentages?
Well, 600 over the year. You're going to take 300.
Well, just go with the heroin usage percentage at first page.
Probably 150
Okay.
in the last 3 months out of 300.
Oh, that's the first quarter?
Yeah.
So you're looking at, what,
Yeah, January,
450
February,
maybe,
March. Yeah.
all told in a year? Wow.
Yeah.
Holy smokes. Okay.
So
Thank
about
you.
half, 150 out of 300. I'd throw it around there.
Okay.
Thank you, Adam.
Or 200 out of 2. Thank you.
I got you.
I
I
appreciate you.
apologize.
too. Thank you.
Our next testimony will be from Dr. Mays. So, doctor? Thank you.
Well, thank you for the opportunity to allow me to talk to you today about some thoughts I have about drug addictions. I've practiced in the Watertown area for 30 years, have a private practice in occupational medicine, worked at the New York State Prison in Cape Vincent for 16 years, retiring in 2006. As a specialist in HIV at the prison, I was offered to take a course to allow me to prescribe buprenorphine. Since then, I've become hooked on working with addicted patients and follow the largest number of patients with opioid addictions on Suboxone in Jefferson County. In addition, I'm involved in inducing patients on buprenorphine, Suboxone for other hospital services, and my practice performs many drug tests for uses by social services, probation, the courts, and child protective services. We have a large experience with the problem of drug and alcohol problems in this county. I'm a member of the American Society of Addiction Medicine, and I'm on the New York State Chapter's Committee on Public Policy. This area is blessed by two strong outpatient addiction programs, Credo Foundation and Samaritan Hospital Addiction Services. These programs are open to all potential patients who choose, and the treatment programs are individualized according to the needs of the individual, and attention is given in terms of advice and encouragement and other issues such as education, vocational information, living and housing, and other services. Patients need to graduate from the program, and if they fail because of non-attendance or relapse or other issues, they are given the opportunity to re-enroll. Many of these patients benefit from using Suboxone as a means of avoiding cravings for drugs and help them stabilize their outlook on life. In general, the treatment of drug addicts with Suboxone can be short, such as 8 to 12 months, or longer as the patients struggle with improving their lives and feeling comfortable being off of the Suboxone. Longer treatment is often advisable as patients require time to develop living skills past their initial addiction program. Continuing with Suboxone allows them to live without cravings and become productive before they come off the medication. Studies are available to review concerning these approaches. Suboxone itself can be difficult to stop as patients become physiologically dependent and suffer withdrawals if the medicine is stopped too rapidly. Tapering patients too rapidly or taking the patient off the medication arbitrarily and before they're ready will lead to relapse. In my practice, I have several patients who have been on Suboxone for 8 years, 3 and 4 years as an average, and some patients are less, of course. One problem is that drug addiction tends to be a catch-all phrase and does not describe the severity of the addiction. Many patients begin their addiction in teenage periods, and in some cases even in preteens. These adolescents are thus subject to brain insults as a result of the addiction that makes overcoming the addiction very difficult. Patients who begin their addiction in their 20s might be perhaps easier to treat, but variables such as family support, education, job opportunities, and the understanding of realistic goals are needed to go through a program and complete it. Before they can be done with their addictive ways, the patient sometimes needs longer treatment and specialized treatment. The longer the patient is addicted is a factor as well. I have patients in their 40s and 50s who have been addicted all their lives and are struggling to remain sober. Some have developed characteristics that make them dishonest to themselves and others. They use drugs when they become frustrated and they lack the ability to deal with life on life's terms. They are anxious, they are fearful, they are depressed, and they are unable to keep a job, unable to avoid a marginal way of living, and they are unable to recognize a life without the support of social services, health care provided by Medicaid. And in all situations, persons addicted are felt to have an illness related to changes in the brain. I have patients who have been raped or abused by family members who have seen their patients abuse each other or whose parents have been in jail for much of their developing lives. I have a patient who received an apparatus to use cocaine as a birthday gift when they became 16 years old. I have a high rate of pregnancy among Suboxone users. I've had a few amazing successes, people who have taken control of their lives, gotten good jobs, and are now successfully living the American dream. I have had several patients who have attended and graduated from Jefferson Community College and are going on to obtain higher degrees. I have a patient who recently obtained a master's degree and was sought after for a job that is paying over $60,000 a year. And he is just now coming off his Suboxone. I have had many failures, people who have relapsed, people who have been arrested and gone to jail, failed probation, failed the addiction programs. I have patients who lie and use and continue to struggle. People are fearful about getting off the Suboxone, and since they lack the confidence to make the changes they need, they don't become successful. To improve our treatment here in Watertown, we should have a detox program. Currently, patients need to go to Syracuse or Potsdam, and we heard from that individual in Potsdam. Thank you very much. It was quite illuminating. There's often a wait time of several weeks or a month to get into detox. The truth is that when you're ready to make a change, you need to do it when you are ready, or other influences will intervene and the patient gives up. Detox can be outpatient and can be more versatile than the existing inpatient programs. Funding will be needed for this to be in place, and flexibility in the development of the service should exist. Detox optimally will run concurrently with outpatient addiction treatment. We need more Suboxone providers. Not all doctors want to deal with the messy issues of addiction treatment. So there needs to be support and working agreements with existing treatment programs so that longitudinal treatment issues can be dealt with. These issues are programmatic, social services networking, mental and behavioral health coordination, case management, job training, partner and marriage counseling, and a host of services that physicians might not have easy access to. Until we have this, doctors will not become prescribers. If they have a particularly difficult patient, they need to be able to seamlessly transfer that patient to a higher level without simply discharging them from their program. What I'm describing is an integrated hub system where prescribers and addiction treatment providers work together in managing the patient according to their individual needs until they can be successfully discharged. We need improved mental health services. 70% of addicted patients have an additional mental health diagnosis. Although we have a new mental health organization in Watertown, it still takes several months for many patients to be seen. And psychiatric services should be part of the hub that I described. Within the hub, long-term group treatment programs should be available to provide ongoing support while the patient remains on Suboxone. A statewide issue is that if a patient is on Suboxone and is arrested and put in jail, his or her medication, just as medicine for diabetes, hypertension, and heart disease, needs to be continued. The patient should not be put in jail and forced to undergo the painful rigors of rapid detoxification in a jail cell. That's just inhumane. Lastly, the issue of legalization of marijuana is troublesome, and it's troublesome to our task force. It's a known toxic substance for the developing brains of children and adolescents. Great damage can occur if the current movement for use of marijuana, even for the ill patient, is implemented. At a minimum, stringent regulatory rules will be needed to control its use, and there should be no consideration given to allowing expanded use to become a stepping stone to legalize marijuana in the state. Thank you again for letting me speak to you today. I have one other comment that I wrote down, and that's about the insurance companies. And they certainly have a huge effect on the prescribing of Suboxone. Suboxone, I haven't said much about it. Most people know something about it, but it's similar to methadone, except it can be given on an outpatient basis, and patients can carry it with them. They don't need to go every day into a methadone program, and it certainly is helpful. It has some negative effects. It often can be abused and so on and so forth. And so that's an issue. But the insurance companies currently control Suboxone, as it were. So we can prescribe it, but we have to get it approved. And they may not approve the dose that we want. They may not approve the dosing mechanism that we have. For example, if somebody is on 16 milligrams and you want to reduce them down to 12, you might want to change them to a different dosage form instead of 8 milligram tablets or strips, but you're often not allowed to do that. If I have a patient coming down from Suboxone and they're on 8 milligrams and I want to reduce them by 1 milligram at a time, it's difficult to do that unless I change the dosage form. Well, they might not approve a particular dosage form. And so I'm telling the patient, well, you got to cut your pill or you got to cut your strip. And, you know, how do you judge 1 milligram from an 8 milligram strip? So the insurance companies have a big say in what's going on. And we have no idea how long they're going to approve them. In other words, if we have somebody who's on that medication for 2 years, they very well may say, well, 2 years is long enough, we're not going to pay for it anymore. We don't know that. So, thank you again.
Doctor, just a couple questions. Do we have enough doctors and nurses and social workers to cover this area? Because I'm always hearing that there's a shortage for doctors in other areas and the counties that I represent.
Well, we are pretty well supplied, I would say. Family practice and primary care doctors, you always can use more of them. But I am the only doctor in practice that prescribes Suboxone. I'm a family physician. I've specialized in that, and I'm particularly interested in addiction problems. We don't have any other primary care doctors who are prescribing. We have 2 psychiatrists right now. There are some who are certified, but they're not really involved. And I can tell you that from my experience, it's not easy. It's not just a matter of writing a prescription for Suboxone, because they need extra services. They need more help, and you know, unless you're willing to give it, you're not going to prescribe.
You touched upon one of the points that I was kind of trying to understand, because when somebody gets to the point, like you talked about earlier, when his son got to the point where he realized he wanted help, and then you go to get services and you're put on a waiting list. By the time you get to that,
right,
your circumstances may have changed. So for how many people are slipping through the cracks that they're not able to get the services they need at the time they're ready to receive them?
Well, I think that that's a hard number to really get at, but it's a significant number. I mean, I think if there are 50 patients waiting, how many of those eventually drop out? You know,
we get
40%,
dozens of calls
100%,
every week for
90%.
Suboxone, and we're at capacity. Dr. Mays is at capacity. So you have a number of people who are ready to come forward, but there's no access to the medication support.
I have people calling me every day to try to get into the program, and I'm limited to 100 patients. That's a lot. There are a lot of doctors who will stay with the initial allowed amount, which is 25.
Do you think we would be doing all we could to make sure that those individuals who are at the point where they're going to try and get help are able to immediately get treatment while they're in that frame of mind, versus sending them back home just waiting for, you know?
Well, some of them might be in a rehab program, and then the rehab program will want to get them on Suboxone. But if you don't have room, you know, then they go searching around for doctors, and some might drive to Syracuse or elsewhere to try to get on the Suboxone, or they buy it on the street because it has a street value.
Same heroin dealer sold it.
But I think the issue that I'm trying to describe is that if we have a really well-honed system where doctors and treatment facilities work closely together, really closely, and then you could pass a patient back and forth. The problem then for the physician of dealing with addiction issues that they might not be capable of doing or don't totally understand, they can give that patient back to the rehab so the rehab can work with that patient and then maybe send them back to that doctor. And there are models in this country where that works very well. Burlington, for example, is one where they have that kind of a hub system where the mental health addiction treatment program is the main entity, and they have a variety of primary care doctors who simply prescribe the medication.
How do you spell that?
Suboxone, S-U-B-O-X-O-N-E. And the generic name, S-U-B-O-X-O-N-E. And the generic name is buprenorphine. I'm going to give you a copy of my...
So, there's other methadone, is that a...
Methadone is another similar type drug, yes.
And these drugs, I don't know anything about these, so just bear with me. These drugs, one, help you detox and also keep you off the addiction?
Well, yes, it helps resolve the cravings that you might have for the use of opiates. Yes.
And what kind of drugs are these? Are they...
They are opioid-like drugs, but they have a limit. Methadone less so, but Suboxone has a limit that it will work. So up to 32 milligrams, perhaps, you won't have any further effect. In fact, 16 milligrams is probably the maximum amount. You can't give more, and you can't get higher, or you can't get high at all. Most people who are on Suboxone, and in fact, not pointing them out, there are a few of my patients here who are on Suboxone, and they'll tell you that it just makes them feel normal, and they function just as normally as anybody else. There's no specific ill effect of the medication. It doesn't make you high.
Great, thank you.
Thank you, Doctor.
Thank you.
We're going to take a short break, say 10 minutes. We're halfway through the testimony, and so we'll take a quick break. Thank you. We're ready to get started now. The next person testifying will be Chelsea Mulcahy. Chelsea?
Hi. I just want to say thank you, and I apologize if I get emotional. I already am. Excuse me. I don't have anything written down. I just have my own life experience with this drug. I don't have good memories. Thank you. I don't have good experience. In September of 2013, thank you, my boyfriend passed away because of a heroin overdose. We lived together for 2 years, and I tried my hardest to try to get him to stop. Unfortunately, like others have spoke today, a big issue is insurance, not allowing him to stay in a facility prevented him from getting clean and staying clean. In September, he finally went to a rehab for the second time. He got out because insurance wouldn't let him stay any longer than 6 days. The day that he got out, he begged me to try to get him help. He told me how he felt like the devil was inside of him. He could not get the devil out of him. Unfortunately, 6 days later, he passed away at his mother's house in the bathroom, and his 10-year-old niece found him. I don't really know what else to do to try to get it out there that there needs to be more help The system is broken. It is not effective whatsoever. In January, we found out my brother was addicted to heroin. Luckily, well, not luckily, but it was not at the point where he was injecting. He was only ingesting by sniffing. So what had happened is we sent him to a rehab facility called Syracuse Teen Challenge. He was there for 90 days and he just got out on Monday. He has a wife who was an RN. He himself was in the union, had a good job, just got mixed up in the wrong thing because he was addicted to opiates for 10 years. And it led to eventually being addicted to heroin. My father, who owns his own company, is sick. He has autoimmune polyneuropathy, and he also has lupus. They give him pain pills. He became addicted to the pain pills, and now he is on a Suboxone, and he will be for the rest of his life. I really don't know what else to say other than there needs to be more options for those who are addicted to drugs, opiates, alcohol, any other drug besides heroin as well, that there just needs to be more options to get help and to stay clean because it's just not working the way it is now. Really, that's all I have to say.
First, I just want to say how much we all appreciate you coming here and telling the story, because if we don't hear, unfortunately, heartbreaking stories like that, it never gets ramped up to the next level to really do something about it. So appreciate how tough that was for you.
Thank you.
And if you, be willing to answer a few questions.
Sure. Yeah.
Can you tell me how long your boyfriend struggled with this before that happened?
Well, probably a total of addiction in general, about 5 years. He was captain of his high school football team. He was an all-state champion wrestler. He grew up and lived right outside of Las Vegas in Henderson, Nevada. It began just partying, the drinking, recreational drug use, turned into addiction to pain pills, which then turned into addiction to heroin. He then decided he wanted to get clean, and he came to live with his mother here on this side of the country. And the kids that he went to high school with, or the middle school with, are all addicted to opiates and heroin, and you name it, they have it, they do it. And it just spiraled out of control. The last 2 months of his life, he was using $700 or more a week of heroin, which is about a bundle to a bundle and a half a day, which I believe is a lot. A day.
You talked about the need for more services.
Right.
And I understand that he didn't get to stay as long as he needed to the last time. What other problems did you run into when he was trying to look for services?
The prices of rehab facilities. I called the New York State hotline to try to get him into a rehab, and they said, unfortunately, the cheapest rehab that we have available is $14,000 a month, and that was the cheapest. The most expensive that they could tell me was $50,000 a month.
do, thanks. And I just want to echo the senator's words. It's really very good of you to come, and I know it's not an easy thing to do to relive some of these bad memories. Can you explain a little, and maybe you don't know, or whatever you're willing to testify, where he got the heroin from?
Yeah, sure. I live in Oswego County in Fulton, New York, where I say we as a county around that area get drugs, specifically heroin, from Syracuse, generally the west side of Syracuse. It's everywhere. You can walk into a supermarket, ask pretty much anybody, they could tell you, oh yeah, sure, right over here on this corner, right behind that school, right over there behind the Boys and Girls Club, right there, right in that alleyway, yeah, just walk back there.
So it's purchased similar ways that my experience, I guess, is seen on TV, or where you're in your car, there's someone on the street, you pull up and say, I want to buy this, they either get a runner to come get it, or, yeah.
Yep.
It's not
It's
someone's
easy.
house, or it's easy. Yeah.
Right. It's incredibly easy to get your hands on. It's shockingly scary how easy it is to get your hands on heroin.
That is scary. Thank you.
You're welcome.
Your brother, how old is your brother?
My brother just turned 27.
Okay. Now, he was in a teen center, you said?
Well, the name of it is Syracuse Teen Challenge. It's not just focused to teens. It's focused to really any it's a men's community.
Now, he was allowed to stay there for 90 days?
Right. They want you to stay there for 14 months. They keep you in Syracuse for about 3 to 4 months and then ship you to Pennsylvania to their other portion of the rehab facility. He has a family. My nephew's almost 5 years old. You know, he's got a mortgage. He's married. He's got to support his family. So after about 90 days, he got out, which was on Monday, and is back to work. Unfortunately, I, as an individual, don't have a lot of hope that he's going to stay clean. And it's sad just because there's been so many times where I've saved my boyfriend's life. Myself, I gave him CPR and brought him back to life about 5 times. Myself. Because I was too scared to call somebody else for help.
Thank you.
You're welcome.
Thank you. We do really appreciate you coming and
Thank you.
talking to us today. Just to let everyone know, the Assemblyman will have to leave before we finish. We want everyone to understand that he believes it's important and has a prior commitment. So, Gene Weaver of Jefferson County has next testimony.
Thanks for allowing me to be here. I just want to begin to say that this wasn't probably any of my life plan to be standing up here and airing my family's addiction issues, but obviously plans change, and I'm here. Hope that some of this experience that I share will help. I personally envision that this growing heroin epidemic is like a black plague that's infecting and destroying our communities, sickening and killing our children and young adults, and has far-reaching consequences. We have a strong family history of addiction. We also have a family history of recovered addicts. My father was a morphine addict. He was a World War II veteran who was very badly wounded and addicted to morphine for pain. And my husband became an alcoholic as a way of medicating a loss of a divorce of his children's. And my son, I am the mother of a heroin addict and alcoholic who is now currently 61 days sober. Finally, at least at this point. I'm also a grateful member of Al-Anon and Nar-Anon, which are the family support groups for loved ones of alcoholics and drug addicts or drug addicts. Very, very important program for me because I was crazy. which living in an addicted house can make you that way, and these support groups are very helpful. But I had a whole laundry list of my family history. Basically, I guess I'll touch more on my sons. You know, he was a brilliant, engaging young man, big heart. He was a college graduate and a stonemason. And like most of us, made some pretty stupid choices, even though he went through all the DARE programs and everything that was there, you know, as a teenager. Like, we never did any of that stupid stuff as teenagers. And in time, he found himself a full-blown heroin addict and alcoholic, and most recently living in an unfinished cellar in a drug house in Pittsburgh, or in a Pittsburgh suburb, which has recently been condemned. And he also had a little bit of touch with this fentanyl-laced heroin that killed somewhere in the number of about 23, I think, people OD'd in about a week down there. He had lost everything. Then this is about the third time that that has happened. His home, his job, his truck, a girlfriend, their baby, and his dog. He was facing 2 warrants in 2 different states. He's currently satisfied the legal matters in the first state and is working on this now. He's reconnecting with his girlfriend and child and working on this reconciliation and is addressing his drug and alcohol problems. He started a new job as an outpatient rehab and through Credo. He attends 2 or more AA meetings a week and does not have easy access to NA, which would be really important. There are NA meetings in Watertown, but outlying areas there's nothing. And a lot of these people don't have their license anymore, so it's really hard to get there to these meetings. So because of that, we're doing a lot of driving, and some of these meetings and appointments are at least a 70-mile round trip. And he's lucky because he's got parents that are standing behind him, you know, to help him do this. He wanted to go into inpatient rehab, but was denied by the insurance company. He did not qualify because he'd been sober for too many days. That's a big problem. He'd probably been sober maybe 3 weeks. So the insurance company has renamed his illness a behavioral problem, which pretty much relieves them of paying for inpatient addiction treatment. The fact is that they do just about what they can to avoid paying for inpatient treatment because it is expensive. And they do, in their contracts, say they provide for these things. And they also work pretty diligently at decreasing the time that they spend in inpatient. And I think, you guys have heard this. That is just one of my issues. And the reason for some of this history that I think that is important for you guys to know is that we, just all of us people here now, we're like regular working class Americans, middle class Americans. We're not the low-life trash that people would think of as a heroin addict or a junkie or a dope fiend in their family members. You can see a stream of BMWs driving into the inner city any day with all these little yuppies going in to get their fixes. You can see on a Friday night a line of young teens and young adults at a pharmacy counter there to pick up their syringes so they can party safely. You'll see a lot of older adults becoming opiate addicts because they are seeking arthritic pain relief. You'll see a local high school lacrosse team with a roster of pill poppers, and I know that for a fact. These kids nowadays have no respect or fear for heroin like we did. You know, somebody said heroin, you ran. This is not the way it is now. This is just one of the pieces of equipment to party with at this point in time. So what I want to say is heroin is no respecter of persons. There's no one that's exempt from this anymore. It's just us, all of us. I wanted to spend a little bit of time with our personal experience, and I know I don't want to run over too much, but life is filled with chaos and guilt, fear, panic, insanity for both the family members and the addict. The addict's loved one becomes so enmeshed in covering for and trying to save their addict that they lose themselves. We become addicted to the addicts, and we become sick. And then we become sick and spiritually, physically, I can say ill. In a point of desperation, which was relatively close in time, I wrote to Dr. Phil. So I told you how desperate and crazy you can get. And he hasn't called me yet, but I'm waiting. I tell you, we'll do just about anything, you know. I want to go through some history of this, but probably some of it would be that he, even though the strong family history, he very well could have become an addict, you know. But he was injured in football at 15, was prescribed an opiate for the pain, ultimately ultimately continued using some opiate on some level and right up through use of heroin. And he said to me he loved the way that made him feel, and he never stopped using it during these next few years. I think I know his use escalated in college, where you will find a lot of drugs to help along with that. By the time he came home, there was a lot of personality changes. He was testy and unhappy, verbally abusive, among other things, would not cop to anything but smoking a little weed. I had an anger problem, went to anger management. There were the next couple of years, there was escalating chaos in our house, strange happenings, crazy friends, missing money, missing anything that wasn't tied down that had any value would come up missing. And, you know, we were clueless, really, to why this. This didn't look like anything I'd ever seen or had any experience with. Finally, after some pretty significant stuff going on, he came and told us about this. And that was just the beginning of our experience of knowing where we were, at with him. He did end up going into rehab in about that time, and they were talking discharge plans. This is not, we're going, what are you kidding me? We're expecting at least 30 days here, day 2. He was sent out on the 15th day with a pat on the butt and a you're cured and a coin and a to-do list. It just wasn't what we tried really hard working with the insurance company. They just said no. He had OD'd at least twice. He has common physical issues, mental, stuff that goes along with this, emotional, spiritual damage from the drugs. He's made suicide threats, and this thing I said, I am in much fear for his life. We did everything. We did everything. We did nothing. We spent money. We enabled. We detached. We removed him from the home. That's really hard, kicking your kid out, especially one that we feel was sick. That was really difficult. Anyways, I think that's about all I'll say about that. But so as I can say, I haven't heard anything from Dr. Phil yet. Anyways, I'm waiting. This brings me to my next concern is that, after reading and researching much of the physiological effects on drugs on brain chemistry, I'm fully convinced that this is a disease. It's a chronic disease that with a known cause, progression, and outcome left untreated. Good news is that you can successfully manage drug addiction or alcohol addiction. Problem herein, and you've heard this area, Jefferson, the Tri-County area, is sorely in need of more treatment facilities, particularly I feel inpatient. The ones that we have are stressed right to their limits with the long waiting lists. And the only way you get into these now, of course, if the insurance company blesses you with this, and that doesn't always happen. As my son was recommended by his physician, by somebody that's in jail, where he spent some time in jail and they had a process they went through there. That was recommended by her and the person at Credo. All sent recommendations in for rehab, and they said no, he's been sober too long. So then your choices are with this out of pocket for $15,000 to $35,000 to $50,000 a month, which we all have in our back pocket, or Medicaid, and he's not on Medicaid. Addicts don't do real well with long waiting periods because they're in the throes of withdrawal, and they're ready. When they're ready, and they're not. Their patience is about like this long, right? So anyways, we need more facilities and outpatient, inpatient treatment, well-trained professionals who understands that addiction is an illness and treat it accordingly, and insurance companies that are going to be required to cooperate a little bit, and more Dr. Mays, because these, you need these kind of people around to deal with this. Another issue I have is, I haven't had the opportunity to stand beside my son in court because many, if not all, eventually find themselves in legal issues. And I certainly don't advocate for the absence of accountability for bad or criminal behavior. What I do feel is that all the players in the legal system become more cognizant that this is a disease process, and that this disease process leads addicts to take part in criminal activities that they would not have been involved in otherwise had they been sober. Their judgment and to conceptualize actions versus consequences is dysfunctional due to the brain damage, impairment through the chemicals. And what I would like to see is more judges placing more emphasis on treating the illness that causes the bad behavior combined with some level of accountability based on the treatment programs. And that is what our judge here recently has done after quite a bit of talking with him, because he was ready to hang him. And maybe he should be, at least he was in there, which scared him. But you wouldn't send a diabetic to jail without the insulin to manage his illness, where do you send an addict to jail without something to manage his illness? So again, we need to work on a better system to meet the needs of the addicts who break the law, especially the large number of drug-related cases seen in the legal system. It's huge. I would hope we would not wait till they're like deceased at stage 4, but maybe where they're committing felonies and really bad stuff, try to recognize their illnesses at stage 1 when the legal issues just begin. And I guess my final one is directed at, I shouldn't say at physicians, but it's about the medical field. I've worked in physical therapy for years. We treat pain with, hands-on means. Doctors are required to assess and assist in pain management for their patients, which has led to this overprescribing of opiates, along with the assistance of the pharmaceutical companies. For pain control, many, if not all, of these patients that are on these opiates, like oxycodone, whatever, become addicted to the medication, and they're taking it because they're supposed to take it. Now, who's responsible for their addictions? Most doctors are not trained or are not really interested in treating addiction, not the addiction they've had a hand in creating, and when there is a doctor who will try to wean the patients off of opiates, they're dropping the amount that they have, so these people need, they're addicted. They're going to go out and find street drugs to satisfy their cravings or to keep them from withdrawals, because the withdrawals are pretty nasty, kind of scary. Rapid Response Group is doing, a pretty good job dealing with this, but for you, I would say the governor of Vermont and New Jersey have started doing some pretty good programs for how to deal with the legal issues and stuff, and I think that would be a model to look at. And I just said, my question would be, considering all the studies about the brain dysfunction, you know, with drugs and the damage it does, especially with the developing brain, you know, why would a doctor send a 15-year-old home with a prescription for Vicodins, 60 Vicodin tablets and 3 refills? He can't have alcohol until he's 21, but he can have Vicodins, you know, and maybe we should rethink that. I said maybe a few days of discomfort managed by Tylenol would be better than a lifelong battle with addiction. So probably I just want to close by saying I probably have annoyed a lot of people, but that's too bad, I guess. I'm just real thankful to see that we're starting, you know, you guys are here, and to help fight this battle and fight for our loved ones, because these are our babies that this is happening to, and they don't know what they're getting into. And I would just say, educate yourself about the disease of addiction. That really will change your mind about this whole thing. So, anyways, I'm done.
Thank you, and appreciate your testimony and appreciate your recommendations, because we're going to forward those on to the full panel.
Okay,
Thank you. Next, we have Detective Sean O'Brien from the St. Lawrence County Sheriff's Department.
Good afternoon, Senator, Assemblyman. I come before you today as a man that's on the boots on the ground. I'm assigned to the St. Lawrence County Drug Task Force. My goal at the end of the day is to target drug dealers, not the users, the dealers. And while national statistics are frightening, I will have before you local statistics in St. Lawrence County. Heroin essentially was non-existent in the law enforcement side dealers before 2012. And I take a step back for a second. The oxycodone that we were faced with, preferably the Oxy 80s, our CDN Oxy 80s that we attempting to purchase, was at probably a high in 2010, 2011. There was a change in the formula somewhere in that 2011, 2012 area. We had a 57.10 decrease in oxycodone sales cases. Now we have heroin. So as I stated before, the direct result of the oxycodone was the change in the formula. And it was difficult to abuse because you could no longer smoke it or inject it. 2013, our heroin cases increased 280%. 2014, we're on track at this particular moment 120% above 2013. We have a problem. And to be quite candid, not to take anything away from the heroin and opiate addiction, but next year, our fear is it's going to say heroin and opiate and meth. Because we need to stay out in front of the curve. This is a result of what's going on. I'm telling you, at least in St. Lawrence County, we have a 500% increase in meth. So we're a little slower up north. The meth, or the heroin is not coming from the north, it's coming from the south. As stated before, the major metropolitan areas, Syracuse, Rochester, Buffalo, New York City, they come to our area. Not only is this scary and frightening numbers regarding drug sales or crimes that were people that are arrested, we have a rise in property crimes. As a few have stated, their children were out stealing, doing what they had to do to get their fix. So it's not just about the drugs, it is about the drugs because it causes the children to go out and offend. Much like the oxy problem, if the source is targeted, you will limit the amount available. Period. Therefore, we need to find some different approaches on what we're going to do. Suggestions? Patrolmen interdicting individuals and identifying individuals that are bringing the product into our communities. People aren't growing this in their backyards. People are bringing it to us. Undercover operations need to be increased to include control buys to identify the sources that are out of the area. To further accomplish these tasks, multi-agency cooperation needs to be established. Now, we do have quite an entourage, if you will, of and a cross-section of the law enforcement community on our task force in St. Lawrence County. But it basically boils down to funding. And, you know, it's all about the money, unfortunately. Sitting here today, our hearts go out to those that have lost their loved ones. It's a tragedy, and I will be honest, as the gentleman that I'm here with today, we were out in the hall at the break, and we said, you know what, this lights a fire under us. So you can rest assured tonight that we will be working our hardest to try to curb this problem. Having said that, a suggestion of mandatory prison sentences that takes the discretion away from the judges may not be a bad idea. Similar to the Rockefeller laws, as the sheriff and the DA spoke of earlier. That pretty much drug prices in St. Lawrence County. You folks here speak of $10 a packet of heroin. We pay $35 to $50 per packet. And it wasn't just once. Constant. So the prices, supply and demand, basic economics, but to pay for a $50 packet of heroin, you've got to steal that much more out of people's cars. You have to steal that much more out of businesses. And like I said, next year, our fear is that it's going to be a heroin and opiate and meth addiction. Thank you.
Detective, can you tell me where you believe the heroin is coming from, especially if it's at a higher rate than maybe has been said occurs in Jefferson or Oswego County?
Like I said, I think I will say it's south. It's definitely seems to be the metropolitan areas in those communities.
And do you believe that the laws on the books are not tough enough now to keep the drug dealers off the street?
That's the dealers.
The dealers, right.
Not the abuser, not the abusers, the dealers.
Right. But I
mean, if you're caught with a certain quantity of heroin, if you're caught with X amount of packets of heroin, if you're with 100 packets of heroin or 150 packets of heroin, you're not a user. You're a dealer. And this person doesn't need to go to, you know, and a lot of good businessmen aren't using. They are making money. They're making profit. I mean, if it's $7 or $10 in the streets of Watertown today, it's 35, just 35 miles north.
Well, I'm sure everyone who's here today, his sole purpose is to help those people who unfortunately got caught up in it, and we want to do our best to make sure that they get put back on the right track with resources because of what it's doing to them and their family. But there are some who are dealing, who are making a profit, who unfortunately are giving the 15-year-old kid the opportunity to get hooked on his first try, and those are the people that we should all be working towards making sure they're no longer on the street.
Absolutely.
Just two things. You mentioned not enough resources for the Drug Task Force. If we're looking for some kind of solutions, is that something you think should be part of the talk, that certain grant funding allowed to the Drug
Absolutely.
Task?
Absolutely. The Drug Task Force in St. Lawrence County has been organized by the Sheriff, Keith Knowlton. And my understanding is that was his center. And he knew the drug problem was coming, and here we are many years later, and that's where the money needed to be spent. Unfortunately, we're strapped for manpower. We don't have enough manpower. And people in the community need to understand that the Border Patrol has a function, that the state police have a function, the Sheriff's Office has a function. They don't see the St. Lawrence County Drug Task Force members because we're trying to blend in. So we need to reallocate or spend a little more in the undercover operations. And I understand the constant complaints of, oh, I've passed X amount of police cars in a 5-mile area. So we need to reallocate money if you want to attack this problem.
Do you have any specifics, or could you pass on specifics at a later time with the number of arrests in the last year?
Absolutely.
Updated? Okay.
Absolutely.
Thank you, Detective. Thank
Okay.
you.
Thank you. Thank you very much.
Next speaker is Anita Seafried Brown, Program Director at Jefferson County Alcohol and Substance Abuse Council.
Good afternoon, and thank you, Senator Ritchie, and all the members of the New York State Senate Task Force on giving us the opportunity to speak with you and bring our concerns to you. The Rapid Response Work Group is comprised of representatives from various nonprofit, county, state agencies, as well as concerned citizens, including parents of overdose victims and parents of addicted children. And we're beginning to address the issues of prescription drug abuse and prevention of overdose deaths in Jefferson County. And as already stated by somebody before, I don't remember who, we do applaud the passing of the ISTOP legislation, or also called the Internet System for Tracking Overprescribing, which is designed to curb the overprescribing of opiate-based medications by physicians and doctor shopping for narcotic medications by patients. The legislation had some unintended consequences. Anecdotally, we know that a number of patients whose narcotic pain prescriptions don't last till the end of the month seek pain relief via heroin use. Others who have used narcotic pain prescriptions non-medically and used to pay $50 or $60 a pill are now buying heroin for less money and get the same, if not better, euphoric high. While we have made some great strides, the scourge of cheap and very potent heroin has created an incredible crisis in the nation, the state, and right here in Jefferson County. According to one member of the clergy who ministers, in his own words, to the least among us, he says that even heroin dealers warn heroin users about the drug's potency. Can you imagine that? Somebody telling you, hey, look, there's some really strong stuff, take it easy on it. This reverend has earned the respect and the trust of the drug users, their families and family members. He is compassionate and believes in the goodness of users, even when they themselves have abandoned themselves. Drug users may implore him, drug users will implore him, even during the deep of night, to come to the aid of a drug user in the throes of an overdose. Some are saved, others die, becoming yet another sad statistic. According to the Jefferson County Medical Examiner's Office, between 2011 and 2013, 48 overdose deaths have occurred. Cynics might say, 48 deaths in 3 years out of a population of 120,000 residents. While sad, that's not so bad. However, let's examine how many people are projected to be impacted by those 48 overdose deaths while using the Center for Disease Control and Prevention's methodology. One death, according to the CDC, impacts 10 persons entering treatment for abuse, 32 persons showing up in the emergency room department for misuse or abuse, 130 people who abuse or who are dependent, 825 non-medical users. So for one death, there is a total of 998 people impacted, projected to be impacted. So let's look at the 48 deaths in Jefferson County. 480 treatment admissions for abuse, 1,536 ED visits for misuse or abuse, 6,240 people who abuse or who are dependent, 39,600 non-medical users, for a total of 47,904 people impacted by only 48 deaths. The deceased individuals may have had their struggles with addiction, a chronic, potentially life-threatening disease that affects the individual physically, mentally, spiritually, and emotionally. Nevertheless, they were somebody's sons, daughters, and husbands, and fathers. They were loved, and they will be missed, even though they may have put their families through living hell while in the throes of their disease. Addiction creates an obsession with a drug of choice and the compulsion to use it, regardless of the known consequences. Heroin and narcotic pain medications have incredible addiction potential. People will lie, cheat, steal, and break the law to feed their addiction. This destructive behavior is a symptom of the disease itself, which affects the user's ability to resist wrongdoing, enables them to justify their behavior, and allows them to ignore any feeling of guilt for their actions. Essentially, nothing is off limits when trying to satisfy the need for the next fix. It is easy to see, but not justifiable, why society views addicts as losers, criminals, persons not worthy of our care and concern. But we all know that addiction does not discriminate based on economic status, on your standing in the community, or your level of education. The good news is that, as with many other diseases, addiction can be controlled and treated successfully. While with proper treatment, even coerced treatment such as drug court, many addicts can live full lives in recovery. Many others continue to suffer in silence, afraid to seek treatment and obtain available services they so desperately need and deserve. Reducing stigma will result in individuals seeking and receiving treatment for their disease, enabling them to enjoy full and productive lives. Reducing stigma, treating individuals, and supporting recovery are also associated with dramatic improvements in all areas of life: family health and finance, higher civil engagements, voting increases significantly, and dramatic decreases in public health and safety risks and associated costs. While reducing stigma will lead many addicts to seek treatment, educating clients about available medication-assisted treatment is equally important. Over the years, advances in medication-assisted treatment and recovery, opiate addicts were supported by methadone and Suboxone, drugs designed to ease opiate cravings. However, these medications can easily be diverted on the illegal market. A new non-addicting, non-divertible medication named Vivitrol is on the market. The injectable medication eases cravings for 30 days, allowing the person to fully focus on treatment and recovery. However, the drug is still quite expensive, at between $750 and $1,000 per injection. Also, many physicians are reluctant to become Vivitrol-approved providers, citing a lack of interest by clients to use this medication and also cost factors. Dr. Mays is one of the very few who is a Vivitrol-approved provider. The Rapid Response Work Group has also been working hard to make Narcan, an opiate reversal drug, widely available. Sometimes we have the notion that only drug addicts, particularly heroin addicts, die from opiate overdoses. Anyone who's using opiate-based substances, illegal as well as legal ones, are at great risk of experiencing or dying from an overdose. Timely application of Narcan will restore breathing and prevent death. The overdose prevention rescue kits are relatively inexpensive, anywhere between $12 and $25. The already mentioned minister is eager to attend Narcan training, and most importantly, he will invite drug users, their friends and family members, to become trained and to receive Narcan rescue kits, as most overdoses are in fact witnessed. Dear Senator Ritchie, again, we appreciate your interest and your time. Supporting education and awareness building of addiction as a brain disease, helping us reduce stigma about addiction, helping us distribute Narcan deep and wide into the community will help to alleviate the drug problem in the community. There is no one single method to begin addressing this issue, as DA Ms. Inchard has already mentioned. It really takes concerted efforts of all sectors of the community to be involved. We have already talked about law enforcement. Chief Courier in Messina, for reasons of his own, he really emphasizes compassionate policing, keeping people who are being arrested accountable, but in a compassionate way. People who are users, they know that they're not living up to their potential. Getting it from the police as they're being arrested, the sense that they're considered perhaps lowlifes or whatever the arresting person may communicate verbally or non-verbally, is not productive and will continue to further disincentivize the individual to help seek treatment that is so desperately needed.
Nita, first I want to commend you for being so involved in every issue. You were so helpful on the bath salts issue, and
Thank you.
You can tell that you don't do it because it's your job, because you do it for the right reasons, because you truly want to help people. And appreciate you coming here today and talking about it. We've heard from so many people testifying that the insurance is a real issue when people are at the point where they really need help, and either they're not able to get in, or once they are there, they're only allowed to stay for a short period of time. Can you tell me what you've seen on your end when it comes to that?
Well, I work for the Alcohol and Substance Abuse Council, which is a prevention agency, and we are not treatment. When we deal with clients who are in need of treatment, we will refer them to a higher level of care. So we send them to Samaritan or to Credo or to another facility in the neighboring counties. So I cannot really speak to the insurance issue directly. I apologize.
And do you think there are enough services available right now, considering the huge spike in use? I know there's been talk from the doctor that he's the only one who provides that one specific drug, and now you're saying that other doctors don't prescribe what the injection
Correct.
of this other drug. So is there something that needs to be done at that level too, to get either more doctors here who are willing to participate in that, or to get other doctors more involved, to ask them to be able to prescribe this?
Last year, Ms. Fitzgerald and I worked very hard to in organizing a physician education program, and part of the physician education program was to entice physicians to become Vivitrol approved. It doesn't even take a physician to become Vivitrol approved. A nurse practitioner can also become Vivitrol approved. I am not exactly clear why physicians are so reluctant to use it. Perhaps there are reimbursement issues involved. Perhaps it is not. Perhaps it is the sense that addicted persons should tough it out and should attend work the steps, work with their counselors, and don't necessarily want to have the addict the benefit of a medication that would ease their cravings. I really cannot speak to it cogently. Maybe Ms. Fitzgerald would be able, or Mr. Scordo would be able to give us some insight. I mean, cost of it is certainly an issue. I tend to think if a business person, a pillar of the community, would come to a private provider and specifically ask for this medication, it is my sense that that person would receive the medication. Number one, the client already knew enough to ask for it, and secondly, the client has enough money to pay for it. And the doctor doesn't have to wait for reimbursement for this rather expensive medication. Now, that medication actually is also available in pill form and is very inexpensive. The issue with the pill form is that it has to be taken every single day, and the addict has to make a decision every single day to stay clean and sober that day. The decision to stay clean and sober is taken away from the addict by the 30-day injection. There is no guessing at, well, my friend from Syracuse University is coming up on Friday, so I'm not going to take my medication, which will interfere with a high, and be ready to party and pick up my medication treatment again on Monday.
Thank you.
Thank you.
Thank you. Next, we have Jim Scordo, Executive Director of Credo Community Center.
Senator Ritchie, Assemblyman Barkley, thank you very much for the opportunity to come to Watertown and hear, as we obviously had a very full house with a great deal of interest in this topic. As everyone has stated, and we've heard over and over today, addiction does not discriminate against race, gender, ethnicity, socioeconomic status, neighborhood you live in, particularly when you look at the opiate addict. Not unusual that you will see an opiate addict that is, we've heard individuals that completed high school, that completed college, that were athletes, that had jobs, and something happened, an injury, a surgery, a medical condition that required that they were on painkillers for a period of time and became addicted. Very common that that's where that addiction starts for many of those individuals. And there's a fairly high percentage of individuals that become dependent on the opiate prescriptions that will then go on to heroin use. You know, we've heard from the iStop program has done a great job of kind of shutting some of that down, but what that also has done is the unintended consequences is resulted in people, the heroin is now more affordable, so they'll switch to the heroin. The addictions to opiates and addictions to heroin is one of the most difficult addictions to treat. I get family members, friends, people who know me, who call and say, I've got a friend, I've got a family member who's addicted, and I hold my breath and hope that they're not going to tell me it's to opiates or it's to heroin, because that's a very difficult addiction, more difficult than any others that we've seen to overcome. The triggers, I can see somebody on the right path and after being in treatment for a period of time, improve their health, put on 30 pounds, get their everything going back in their life, get a job, have an apartment, and everything going well, and then a trigger, and then something happens where they're drawn back to that addiction. We've heard that over and over here today of different individuals who've experienced that. We've seen an increase in individuals who come to seek treatment at Credo with both the opiates and in the heroin. If we were to look at our residential program, our women's program, Oasis has a criteria that if they're pregnant or if they're an IB drug user, they get top priority to come into residential treatment sooner. 95% of our women who are in our residential program have an opiate addiction because of that. They take priority over any other addiction, and we have a house full of them, 15 individuals, and 5 of them have their children with them. In our adolescent program, we've got about 90% who are addicted to either opiates or heroin. When we look at the treatment approach, across the state and across the nation, we have not had great results. This is a very challenging addiction to try to help someone overcome. We've taken a look at many different approaches. We found that an individualized treatment approach, a holistic treatment approach, perhaps is the best way to go to try to treat that individual. Medication-assisted therapy, as we heard from Dr. Mays. And we may need to make sure that we're treating what was the underlying reason that perhaps led to this addiction. Was it a mental health issue? Was it a trauma issue that they're blocking the emotional pain? Or was it a physical? Was it a primary care? Was it an old injury? So we need to make sure as part of our treatment approaches that we're dealing not with just addiction, but we need to deal with their mental illness. We need to make sure we're addressing their primary care. So if there's that injury that needs medication, we can do so and not put them at risk of falling back into that full addiction with the opiates. You asked a number of the speakers what your recommendations were. I've been in this field long enough, and I don't remember what the epidemic was, whether it was the cocaine that we were facing or what it was, but I'm not even sure whether it was the 80s or the 90s, but we identified a 3-pronged approach, that it needs to be a combination of law enforcement, it needs to be prevention, and it needs to be treatment. And we need to focus on all 3. We heard the detective from St. Lawrence County talk about they need resources. They absolutely need resources. They need to be able to buckle down on the dealers that are coming into our communities. They're not our local people who are dealing. These are people who are coming in. Read the papers. Look at the names there. They're not names that I recognize at all that are from their community or from the North Country. These are people from outside of the area that are coming in here, and it's a business. It's a business, and they're making money off it. So law enforcement needs some dollars. Prevention needs dollars. Years ago, I remember when the Alcohol Substance Abuse Council was in a good share of the schools having a student assistance counselor that was there for all of those students. And if they were in every one of these schools right now, I'm sure that one of the things they would be talking about and doing presentations with students on and getting families in the audience, they'd be talking about opiates. And if you need, I could tell you how many schools they were in at one point and what they're in now. And it's not that the schools didn't want them, is that the schools could not afford that. So we need to make sure that we're putting money into prevention and education to prevent this from happening. Despite all those efforts, we're still going to have some who are going to need treatment. And we need to have the full continuum of care. We can't just say, well, we're going to do this in an outpatient basis. We need to have detox available. We need to have inpatient treatment. We need to have outpatient treatment. We need to have various levels of residential care. We need to have permanent supportive housing, apartments available. We need to have employment vocational services as part of that. Case management services as part of that treatment. I'm concerned, as we were hearing earlier, about what we're seeing with insurance companies, and they're denying individuals inpatient care. I'm concerned as we approach a managed care environment in 2015, what is that going to do? What is that going to do for people trying to access care? Are we going to be looking at shorter length of stays? Are we going to have to continue to send individuals out of state? Why is that happening? Why do people in New York have to go out of state for treatment? That's ridiculous. We should be able to treat those individuals here. I'm concerned that as we deal with this addiction with opiates, that research will show that longer lengths of staying in treatment produce better outcomes, particularly for the opiate addict. And are we going to see shorter length of stays driven by managed care? Are we going to see that they need to fail 2 or 3 or 4 times in an outpatient before they go inpatient? How many of them are, before they end up failing that 3rd time, how many of them are going to end up dead? We need to work around that. People who have mental health, to think that all of these individuals, we're going to be able to treat them on an outpatient basis is not realistic. We need to make sure that we have other levels of care. Otherwise, all we're going to do is we're going to shift the cost. We're going to shift the cost to our local state, or our local jails and our state correctional facilities. We need the beds for, as the detective was talking about, we need those beds for the individuals who are dealers. Those are the individuals that we need to be incarcerating. We don't need to be incarcerating somebody who has an opiate addiction or has an untreated mental illness. Those individuals deserve the right to have treatment. This is 2014. So I'm pleased that we have representation on this task force. I see this as an opportunity. I think the New York State Office of Alcohol and Substance Abuse Services is willing to take a look at how we can go about enhancing treatment services. There's a residential redesign committee that meets every Friday. I'm on the conference call every Friday as they take a look at, as we go towards a managed care environment, how can we make sure that residential treatment is still an option and still available, and that managed care cannot deny that and say that's we're not going to do that as it currently happens. As they start working towards the parity laws, making sure that the private insurance companies recognize that addiction and mental illness should be treated very much like somebody who's, if they've got cancer, if they've got heart, if they've got diabetes, if they have primary care and they need to be treated in a hospital setting, then that's what they need to do. We need to advocate for the same. We'll be happy to be a part in anything we can do to assist you in your efforts, and we look forward to working with you.
I know Anita touched on the stigma that goes along with this. Can you tell me, in your opinion, how we need to change that? How do we start to change that?
It's an ongoing process, and you would think in 2014 that we would be past this. This is not 1970 when addiction and mental illness was really, there was a stigma attached to that. We've made great leaps and strides with that, but it still exists. It still exists, particularly if you're an opiate addict. When we had the whole media thing, they wanted to do a story, Channel 7, I was cautious about putting any one of our individuals who's in recovery from opiate addicts in front of the TV and showing their face when they're trying to get a job in this community or they're going to JCC, and how they're portrayed as an opiate addict, and what people vision more so than any other drugs is that person with a needle stuck in their arm and a junkie. And the stereotype, now, geez, I got that person employed, or the person that comes in, did you know that the person you got sitting behind the counter who waited on me is a junkie and an opiate addict? That's the mentality that still exists, particularly with opiate addiction. It's ongoing education. Come back to my prevention education piece. We need education. That's important to help overcome that stigma. It's a difficult battle, and it just needs to be ongoing constantly.
Thank you.
Thank you very much.
We have a couple more speakers. Penny Morley, Prevention Director of Farnham Family Services.
Thank you. I don't know, he's kind of a hard act to follow, but ironically, prevention, I believe, is really the key. You talked about earlier, or someone talked about going into schools and doing education. It's not just education. The student assistance counseling that he spoke about, we have in Oswego County, and we're in 5 school districts throughout the county. We used to be in 8. And it makes a difference to those children to have a connection with an adult that they can count on and that can help them with those decision-making skills. One of the people that spoke earlier said, I didn't know how to deal with my feelings. That's something that our kids aren't being taught necessarily at home, so we need to help them with that. And that's what we do. Help them learn how to cope with their feelings, help them make healthy choices, all those things that, you know, we kind of take for granted sometimes. They're not getting taught. So that's what we do in our program. Another thing we do is talk about drugs and alcohol, you know, what's not helpful for them to use, those kind of things. Starting at very young ages, we're in K through 12 in our schools. And so really you start out with very simplistic things, you know, not putting things in your body that wouldn't be healthy. And then when you get to middle school, talking about drug use, over-the-counter medication, and the actual prescription meds, because that's where we're seeing kids are starting. They're starting in 7th grade. It's not, oh, they're in high school, they're going to start using someone else's medication. They're bringing it to school, and they're sharing. So that's something we talk about in the schools. And one of the things that that I think is really important is we need to talk to our kids, because they do listen. And that's something, if I could say one thing to a parent, talk to your kids. No matter how much they roll their eyes, throw their hands up, say some nasty things, they hear what you have to say, and they will listen, and it'll come back to them. It's not the only answer. There is not one answer, but it does help. We also, the information I gave you at our agency, my director couldn't be here with us today, so I brought some agency information as well. From 2010, our heroin use of our clients was 2%. To 2014, just starting 2014, from January till today, or sorry, Monday, 16% of our clients are using heroin. That is a huge increase. And we started seeing a rise in late 2012, early 2013, and we've talked about all the reasons that started. Those unintended consequences, you know, had happened, but we're addressing them now. So we started an opioid group for the agency for people that were in treatment. We also have a doc that works with us that does Suboxone, so he works closely with our staff. I believe there's only 2 doctors in Oswego County that provide Suboxone treatment. So, and Oswego County is pretty big, so we have waiting lists as well. I can get those numbers to you too if you want those, because I don't have those off the top of my head, but I can get them. So the increase in heroin in our city is frightening. The city of Oswego is seeing an increase, and Fulton. Ironically, I wish the sheriff was still here, because our people that are coming into treatment are not reporting heroin use in the outlying areas. They're reporting still meth. So I'm with the gentleman behind me. We're a little slower over in Oswego County with some of our development, but we are seeing heroin increase in the city areas. So from self-report from our clients. So that's the information I have in that regard. I spoke with one of my contacts at Oswego Hospital. I wanted to know how many overdose people they get in the ER. And she said, you know, last night we had 2. And in the last month we've had 10. I mean, that's Oswego. It's not, you know, it's not a huge population of people. So we're seeing an increase in heroin. And we're trying to address it in our treatment, and our prevention counselors are addressing it with our youth. And it's really going to be very important that we have that two-pronged approach that we can do. And it's the funding piece is so important, because if we don't have funding, our counselors aren't in the schools. I'm a grant writing fiend, and I do my best to get money in, but there's not a lot of money out there. So one of the other things I wanted to mention, I sat with Mr. Barkley about a week, 2 weeks ago maybe, and I had mentioned this to him. Something we're trying to do is form a coalition for Oswego County to address drug and alcohol use in adolescents. And we used to have a coalition for Oswego, but that was many years ago. So we're trying to get this coalition off the ground so that we can try and apply for some drug-free community funding, so that maybe we can actually address some of the other issues, the more environmental issues that we see. So.
Can you elaborate on the programs that you have at the schools? Is it one counselor per school? Is it full-time?
That's a great question. I actually have 3 counselors. I have a counselor 3 days a week at APW High School. Then she goes to Phoenix Middle School and Phoenix High School. Those are her schools. I have another counselor that just covers the elementary schools in Oswego. She covers all 5 of them. And then another counselor that covers Mexico Middle School, Mexico High School, Oswego High School, and Oswego Middle School.
And the counselors, do they go into each class? Are they in an office so the kids can come in and talk to them? How does that work?
The majority of their time is spent working with students either one-on-one or in groups. And students can self-refer, students can be referred by a principal, by a teacher, parents call us. They also do classroom presentations, but their main goal is that focused one-on-one or small group interaction with youth. We use the 40 developmental assets. I'm not sure if you're familiar with that, but one of those it's been hugely studied. I can send you some information on that. But one of the things in there is if you have one connection with an adult as a youth, just one, you can be more successful. So if that one person isn't your parent or a relative or someone close to you, it can be that student assistance counselor.
Do you have any idea how many kids would come to the counselor on their own to speak with them?
Oh yeah, I have all those stats. I can send you numbers. Roughly, the students that seek out the counselors usually are at the older ages, and I'd say probably half would actually come on their own. So,
if you could get me those numbers, that would be helpful.
Absolutely.
As we look to find ways or look to fund certain programs, this sounds like something that for those schools that have someone there, they have a great advantage. But for the other schools, that's too bad that they don't have the same counselor there for the kids to reach out to.
We used to be in Fulton City Schools K-12, and the funding dried up probably 10 years ago, and people still are like, aren't you coming back to Fulton? Aren't you coming back to Fulton? And it's a money issue. The money, the drug-free schools money that they had no longer exists in the way it did, so we have to try and find other funding. So.
Thank you.
Yep, thank you.
I really have more of a comment than question, although the numbers that, I think you told me the numbers that the counselors actually see in the schools.
Yeah, I can't.
And it's pretty substantial, though,
yeah.
if I recall.
Yeah, but I don't want to quote a number and have it on record and be wrong.
Right. And
but I can send it to you.
Yeah, I don't remember the specifics of who voluntarily goes versus who's referred, or who goes on their own versus. I just want to compliment you. I think you guys are doing a really wonderful job, you and your director in Oswego County, and I look forward to working with you on that. I know you've been in touch with my office about the child care council, and we'll definitely help out any way we can.
Excellent. Thank you so much.
Thank you. Sherry Moore of Jefferson County.
Hi, I'm Cherie, and I'm actually from Lewis County. I'm a member of the local Naranon Family Support Group, a wife, mother of 2 children, and I have a successful career. Just to let you see a difference in backgrounds, I grew up in a middle-class family with no addicts in my life. My father was a successful insurance agent, and my mother raised us 6 children. I have been married to my current husband for 18 years. My 2 children grew up in a home with no alcohol, no drugs, or even prescriptions in our home, other than the common antibiotic. We have both worked and have successful careers, but I am currently dealing with a heroin addict. My daughter has worked in jobs since she was in ninth grade with the summer youth programs and fast food restaurants. She took a civil service exam at 19 years old and obtained a job with the county. She has always been very dependable, reliable, and a hard worker. She worked overtime, holidays, and whenever she was called in for all her jobs. My daughter has always been very responsible with her bills and has excellent credit even to this day. She has never been in any trouble at all, anytime, until recently. In 2011, when my daughter was 24, she moved out on her own with a roommate. This roommate introduced her to heroin and other acquaintances, people, and she started dabbling socially. It was not every day, and she could take it or leave it at first. She was still working, making good money, saving for a new truck, and looking to buy a house. She had a great life ahead of her. Then, in 2012, she met a person that she liked, a male friend. There was a drastic change in her behavior, attitude, and lifestyle. She quit her county job. She was impossible to talk to, get a hold of, or even get any sort of comment from her or commitment for anything. She worked a couple of minimum wage jobs, but her life was a mess, and she had made mine a mess. I was in constant fear for her life since I knew this person was abusive, and I was going crazy trying to figure out what was going on and how to help her. She lived in a camper trailer with no heat, electrical, running water, etc. She wasn't raised this way. She would still take a shower daily at a relative's house, but she was not keeping up with the hygiene she normally did. She lost a lot of weight and was not eating properly. During all of this, she maintained jobs and was high functioning and kept her bills paid, even though she went through every bit of her savings and took a loan out for more money. I can honestly say that with all the changes in her life and the downward motion she was in, she never stole from our household or any member of it. This went on until February of 2013. She came to me and her brother asking for help. She admitted to the drug use, that she was an addict and knew she needed help. This was the first time I really knew what was going on with the changes in her life. She had only been using steady for less than a year. We were trying to research and figure out help for her, but because she had no insurance, actually she was in between because she was turning 26 and was losing our insurance, there was nothing available. She was on unemployment, which made it too much money, just not enough for Medicaid. She didn't make a lot of money at her jobs, but again, that was still too much for Medicaid. She had to move back home. She was laid off from her job and on unemployment. She was really trying to get her life back in order. In May of 2013, she met up with the person that she had been with previously, was in the wrong place at the wrong time. To me, it was good to some degree because of some of the outcome, but it is affecting her life for the rest of it because of the system. She had this person in her car and they were stopped. My daughter was arrested because it was her car. She had no idea what this person had with them. There was no charges for possession, sales, or driving under the influence. The charges were for manufacturing meth. There was no meth in the car and nothing mixed together as in manufacturing. There were items in a bag that could be used for meth. My daughter had no idea they were there and to this day has no idea how to even make meth. It was not what she had ever been involved in. She spent 45 days in jail and was appointed a lawyer from the courts, not a public defender. This lawyer visited my daughter one time for less than 10 minutes the whole 45 days she was in. I was the one that informed him she was housed out to Oneida County. He had no clue. I had called him several times upon my daughter's request because in jail you have no access to call your lawyer, asking him to please go meet with her. There were things she wanted to discuss with him and she had questions. He insisted that she knew what she needed to know and told me not to call his office again. This is a lawyer being paid by the county to do nothing. How is this a good thing? Well, while in jail, my daughter met with a counselor for pretrial release. She was honest and admitted her heroin addiction, hoping that she would get help from someone. She was released on pretrial, and in the course of the past year, my daughter has been in 2 inpatient rehabs. The first one was 28 days. In the second one, it was 6 weeks only because it was a 3-week program. The jail, she was sent to jail in between the 2 rehabs because the judge decided she needed help and she was going to sit in jail until she got into the rehab. When she got in the second rehab, it was for 3 weeks. She had to stay 6 weeks because she had to wait for a bed for a halfway house, which they didn't tell her she was going to till after she was in the rehab. In the rehabs that are 3 weeks, you're sitting there, you're doing the program. When you have to stay longer, you're just repeating the same program. Will it help to repeat? Yes, to some degree. But it also does not help because you're not getting any extra help. You're not getting anything different. She put herself, before she went to jail the second time, she was doing outpatient rehab weekly. It was minimum, 2 days a week. She put herself into extensive outpatient, and she is currently in the halfway house. She still only saw her lawyer 1 time, except for 5 minutes before court, and I know this for a fact because I was with her every time, during the whole 2 stints of 45 days each. So that was a total of 90 days in jail. She saw her lawyer once. She is currently 6 months clean. She will be coming home in a couple of weeks. You are probably wondering why I'm giving you all this background. Well, my main concern is stigma with the system itself. These are people that are degree educated but not street educated. They are supposed to be there to help people, they're supposed to be there to help and to help the people that are innocent. Well, they are supposed to be there to help, and people are supposed to be innocent until proven guilty. Well, I learned an eye-opening lesson this past year about our so-called system and the people that work in it, and this is Jefferson County that all of her legal stuff was in. The lawyer had nothing good to say about my daughter, and he does not even know her. During this whole situation this past year, he did nothing to help her, would not meet with her, tried to cut deals, and said to her face, "I don't care if you go to trial, it is more money for me." He called her a severe drug addict in court in front of everyone present that day. He doesn't know what she even does for drugs, how often, how much, or for how long. Another situation with stigma in the system. During one of the outpatient meetings, my daughter met a very nice young man that was there for alcohol abuse. He was mandated by drug court. They struck up a friendship and were really supporting and helping each other. They encouraged each other to go to outside NA and AA meetings. This person was honest with his drug court counselor and the judge and let them know about the friendship. The counselor gave him a hard time from then on, telling him that he had to stay away from her, that she was a low-life loser, that she was no good for him. She doesn't have a job, and she is a drug addict that he does not need to be around. This is coming from a person that has no clue about my daughter's history. The judge and the counselor would make comments when he had to report and were repeatedly asking him if he was still hanging around her. He was told that if he did not drop the friendship, he would not graduate from drug court. The counselor insisted he spend no time with her and that he tell her to get lost. Who are they to judge when a person is good for another person or not? Who are they to judge my daughter, degrade her character, and call her a low-life loser when they have never met her? Do they know her life history or her situation? No. The insurance companies, again back to insurance because it does fall back on them, they're fighting the treatment of drug addiction. They are trying to say it is a behavioral problem. Drug addiction is a disease that affects the brains. Drug can alter important brain areas that are necessary for life-sustaining functions and can drive the compulsive drug abuse that marks addiction. I talked to my daughter before I came here, and I asked her her opinion, and I asked her as a drug addict in the system, in the jails, in the rehabs, in the halfway house, what she felt that these people needed and she needed. Part of it was this area has a huge health problem with diseases and Hep C due to the uncleanliness of the drug users that have no choice. In all honesty, drug abuse and addiction is so large across the USA, it'll never go away. We need to work on making people healthy the right way, and then you will see a difference. The area needs to implement a needle exchange program. People cannot afford to get clean supplies or dispose of their dirty needles supplies the safe way. Not to promote the drug use, to promote safety, to promote health. A needle exchange program will help protect the public, the little 3-year-old playing in Thompson Park, the grade school kids out on the playground, etc., that don't even realize when they're picking up something and they're jabbed with a needle, that now maybe at 8 years old they're getting Hep C from a dirty needle. The needles get thrown out improperly, and anyone that comes in contact with them can be exposed to something. The drug addicts have no access to sharps containers. They have no access to dispose of these. It's going to be there. It's always going to be there to some degree to help with that. To me, I looked at both sides and I said, well, you're promoting the drug addiction. She said, no, you're helping with the safety of the youth, because these drug addicts will throw their stuff anywhere. They don't care where it is or who gets it. I don't know if you want to hear about my opinion on the legal system, so I'll go on to treatment. Treatment needs to be longer than 2 to 3 weeks. Just because they are over the withdrawal, detox does not mean they are better and now have behavioral issues instead of disease issues. Not everyone should be classified the same. The system needs to treat each addict situation separately. Everybody that talked today mentioned they need to have individual plans, and they really do. Most people are dual diagnosed with mental health and drug addiction. Some are just addiction. They should not be put together in the same programs such as outpatient, rehabs, halfway houses. They need to be treated differently than each other. Halfway house people have to follow the same program no matter what the addiction or mental health problem. Local outpatient programs are the same program, structured the same for everyone, no matter what the issue, drugs, alcohol, mental health. It doesn't work. There needs to be a separate program that deals with the specific problem. Then there is the issue of getting other help if needed. Inpatient treatment, rehabs, or treatment for cravings and withdrawal. There are addicts asking, begging for help to change their life and get clean. This is exactly what happened to my daughter before she went to jail the second time. She was in extensive outpatient. She was at mental health. She had counselors, she had group counseling, she had individual counseling. She begged everybody to help her with the cravings. Nobody would help her, nobody would talk to her, nobody would give her the time of day. In October, she got frustrated. She relapsed. She didn't relapse because she wanted to. She relapsed to prove a point and to try to get some help. That's when the judge put her in jail for another 45 days. They get frustrated and mad, and then they say, the hell with it. No one wants to help or cares that they want to get help. My daughter put herself in the extensive outpatient because the local program wouldn't. The regular program is group 2 times a week for an hour, one-on-one 1 time a week for an hour. Intensive is group 4 times a week for an hour, one-on-one is every 2 weeks. She begged everyone for help and ended up back in jail for another 45 days. Group treatment needs to be structured like NA and AA meetings, and this is coming from an addict that has been through them all. They need to be able to discuss current issues going on in their life and get help with real suggestions. Examples of actual experiences, stories of how other addicts handled similar situations or got through it. Right now, they only do state-required work pages. They are all general and really don't do much to help the addict. She goes currently in the halfway house. She herself is going to an NA or an AA meeting once a day, 7 days a week, sometimes twice a day, because she wants to, because that helps her. She goes to the group 3 times a week because it's mandated. She doesn't get that much help out of it. In jail, there is no treatment or help at all. If you are detoxing from heroin, it can last up to a week. They make you suffer. They do nothing for it. There are meds to help with withdrawal, but in jail, no one gets anything. There is practically no counseling in jail. You can sign up, but good luck if you see anyone. My daughter was in for a total of 90 days between the 2. She signed up first thing both times and never once saw anyone.
Thank you. We have one last speaker, Aaron Bortel from ACR. Is Aaron still here?
No, they've left.
All right. I guess we're all set. Thank everyone for coming. All the testimony will be forwarded on to the full Senate Task Force, and appreciate everybody staying longer than we were supposed to, but the testimony has really been helpful, and appreciate all your time. Thank you.